evoke a lot of negative emotions towards the child. And then you also need to see how are the parents these days. Both the parents are working online or work from. There's very minimal quality time to the child. Most of the time, if they are left on their own, not playing outside or not having that enough stimulation outdoors, is also can lead to a lot of frustration, anger, boredom, can present with externalizing behaviors. Always look at what is the 24-hour routine like this child, starting from the time the child wakes up till they go to bed. Attachment we talked, look for first 2 years. Where was the child? What was he doing? How was mother? What kind of relationship? Whether mother had any psychiatric illness, medical illness, because of which the attachment got disrupted. How would you like to see the child? Obviously, mother has brought the child with lot of complaints, and she is saying lot of complaints in front of the child also. He's angry, he's blah, 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 everything. Not a single thing which is positive. So ideally, try and see whether you give some activity to the child and engage, like drawing, coloring. Ideally, if you are working with a psychologist or someone who is helping you, so try not to discuss or let the mother blurt out all those things in front of the child. Whereas it can be a little different for adolescents. They want private space. They won't open up. So you need to tell them that it's private, confidential, the conversations, unless they are risky. And then go ahead, understanding their part of the story. It's important to know or miss a lot of learning difficulties. So I've made a rule that any kind of a behavior or problem the child comes with, the stressor is academic unless proved otherwise. These days, the academic stress is so much that it is root cause for a lot of other problems. So try to see what kind of a reading or writing the child has. If you ask the parents, they will say, oh, child is very good. They do very good in studies. But when you try to make them read or write, it's very difficult for the child. You will see that that's one of the important areas of evaluation which we miss. And then look for what kind of a family, functioning, social surroundings, then intelligence of the child, and then multi-source information. Because every time you just see the mother and don't get the whole picture. Try and see if you can get information from the school counselor, if they are not. Parents are little wary about informing school about child's problem. The child is going to a tuition, then can the tuition teacher give some information? Or a counselor who is working in the school can give us some information about the child's activity levels and behavioral issues. The rating scales help us. Vanderbilt is one important scale which I use, gives good idea about ADHD, oppositional, and conduct centers. So Vanderbilt is very important scale. I also do RCATS. RCATS is Revised Children's Anxiety and Depression Scale. And you will be surprised that any child who is coming with externalizing behaviors would also have a lot of anxiety or emotional issues. And sometimes they are the source for challenging behaviors. Unless you do a assessment, you won't find it. So make sure that you also look at internalizing problems which should not be missed. Look for syndromal features. Common ones are Fragile X, Down syndrome, Rubinstein type B, Prader-Willi, and those syndromes. And because if you may of thinking of starting medication, so you should have baseline weight, height, blood pressure, then just a auscultation of the heart. Not to forget that what you're seeing can be a normal variation. Yes, look for attachment difficulties, sensory processing difficulties, situational hyperactivity, and then neurodevelopmental disorders. Tics and chorea can be falsely presenting as hyperactive. Thank you.
Thank you, Dr. Vinay. Can you bring the laptop again here? See, it's here. It's here.
So now I would like to introduce the third speaker who will be discussing on the management of externalizing disorders. Dr. Siddheshwara BL is currently working as Associate Professor and in charge Department of Child and Adolescent Psychiatry, LGBRIMH, Tezpur, Assam. He has done MD Psychiatry from the same institute, DM Child Psychiatry from NIMHANS, postdoctoral fellowship also from NIMHANS, and he has awards to his credit, including Govinda Swami Award for Best Outgoing DM Child Psychiatry 2019. With this, I would like to request Dr. Siddheshwar to start his deliberation. Thank you.
Yeah. Yeah, so thank you, Dr. Syed and Dr. Vinayak. So we understood from Dr. Syed's talk the conceptual understanding of externalizing disorder. And from Dr. Vinayak's talk, we understood the classificatory system, how the symptoms presents, and assessment part. So now what I will do is that I will briefly take you through um, the the exact what you should be doing in your clinics. So I won't be talking about the well-known programs or packages. Instead, I will be focusing on certain skills as clinicians that you can implement in your busy OPD. Okay, so because in our routine practice, we and also the follow-ups are very poor. We seldom have opportunities to have full programs. So that is the idea. Just to connect my presentation with the previous speakers, I've shown this picture. So when we come to the management, uh, the important areas for us to look is the school, where some of the interventions can be planned, then the parent, uh, peer group, and the community. But my presentation will largely focus on the parent because that's something known to have a highest weightage in most situations. So this important slide, where I have shown
how
the
the
weightage
weightage
of
of
different
different
treatment modalities have evidence. If you see the first pie chart for ODD and CD, there is only around 10% of the cases we use only medication, but rest it's always the psychotherapy. In the ADHD part, if you see combination treatment, 90% of the cases we use combination of treatment. So usually in our hospital we get complex cases, uh, very less likely that only psychotherapy is used. So I guess that that's the same pattern in most of the hospitals. So usually it is a combination that we use. Medication wise, I think most of them are well versed. So I'll be majority talking about the non-pharmacological treatment. At the end, if time permits, a little bit of pharmacological treatment will be discussed by Dr. Vinayak. So as I mentioned, our main target is parent. Uh, Again, this should be decided on a case-to-case basis. There could be some cases where parent problems could be minimal and probably neighborhood issues could be more. So in that case, we need to be flexible enough to include components to address the neighborhood issues. Uh, why I have selected parent is that most often there is issues in the family and parenting. That's the reason why I'll be focusing on the parent. Now, the general aspects is that the primary idea is that we will redesign the environment of the child so that it can support compliance behavior. That's the whole basic idea. So all our efforts will be to support compliant behaviors. Whether we draw from a family model, systems model, or we draw from a cognitive behavioral model, or any parent training, everything is geared towards supporting compliant behaviors. And we can use both directive and non-directive approaches. Most important thing is that we need to model in our sessions. We just can't keep talking, without that it becomes difficult. So that's the reason why I will be having small experiential learning activities, so that we understand the way in which it needs to be done. And we have the freedom to actually mix and match various different techniques. So don't worry that a program which has been tested in RCT, it exactly has to be implemented. So depending upon the case, individual cases, you can always have the freedom to be eclectic, and you can have abbreviated smaller sessions, maybe because as I mentioned about the poor follow-up, even I think one contact with the parent should be sufficient to offer some form of intervention. So just believe in that. If the parent comes back again, that's good enough. So we will have more things to work on. But always believe that just one session, at least some key important elements can be introduced to the family. I would have loved to have a very circular arrangement, but that's fine. So we'll do the first activity. With the first activity, I want maybe 3 volunteers. Uh, any 3 volunteers can come forward. Since this is related to child, I want you to be free, be expressive. There's nothing right and wrong. I think that was the first sentence Dr. Syed mentioned. So any 3 volunteers, at least 2 I need for now. Anybody? Come. Any? Come. Yeah. So when we are working with children, too much talking can be boring. So this is the important message that I want. Yes, I want the recording. Please. And it should be more of activity based. No. So the other one, sir, can record. Yeah, can record. Yeah. So when we're working with children, a natural play, becomes a medium of engagement. Natural play becomes a medium of assessment, and it is also a medium to intervene. Okay. So I will be using natural play. So I will ask our volunteers to engage in a brief natural play, which will be recorded. I have a set of toys that has been randomly picked up. So there is no preconceived, plan around it. Okay. So it's natural. So who is going to be the child? Yeah. So yes. Yeah. Yeah. You can be the parent, and she can be the child. Yeah. So there's nothing, you just have to engage. The recording has started. So
arrange the pieces with patience.
Don't do it this way, do it the right way. Why are you taking so long? Because you take too long to finish small things. I don't understand what's taking you so long. Time is running. Finish quickly.
Excellent.
thing,
Excellent.
excellent,
Round of applause for the participants. Yeah. So while working with children, there should be a lot of excitement, a lot of initiation. Inhibition can be a little bit less. Okay. So this is the first takeaway. Please. So now, can you please put that video recording screen. So now what we will do is that I'll just project the recording of the video. Yes, yes, yes. So we will just, analyze the moment to moment interaction between the mother and the child. So I did not give any instructions, as all of you observed. Neither I gave any hint about the age, although I have just mentioned there. I did not mention that as well. So it is very natural. Although we don't have the actual child, but I want you to imagine. Definitely, you would have come across all these things, in your personal life. I hope a majority of them have children. So who don't have also would have seen in their clinics. Okay. So we'll just watch the video very closely, and we will try to answer some questions. Okay. So all of them can just read the questions and try to think about it. Okay. Uh, we will be shortly coming up with the video. Till the audio comes up, I'll discuss a few aspects about therapy, when working with children. So as I mentioned, there's no single formula. We need to customize, individualize. And when we work with children, um, although there is evidence for certain form of therapy, say for example parent management training has the maximum amount of evidence, but there could be cases where you might have to incorporate more of cognitive behavioral elements. There could be cases in which more of supportive elements, say the child would be showing a lot of externalizing behavior because of some past trauma. So you can't just, use the reward punishment, paradigm, indiscriminately. So that individualization is,
Sir,
essential. Just hold on, I'll just finish this. So when we work with them, when we work with children, we also need to understand that things won't work. Okay. So despite repeated sessions, despite repeated efforts, um, the symptoms don't come down. So what to do, in such circumstances? The first thing that we need to do is that try to understand the comorbid conditions, comorbid risk factors. Okay. And then, if possible, we need to understand the family factors, the psychiatric comorbidities in the parent. Okay. And then we need to try to intensify the sessions if possible. Okay. Whether, it involves, mm, having a longer session, or it could also mean, improvising into having shorter session. It depends upon, the case. So some such sort of improvisation is essential. And then, sometimes despite improvisation, we are in a roadblock. Okay. So we at that point of time, we may have to reconceptualize the case. Okay. Not everything will be related to problems in family. Not everything will be related to the school. Okay. So if you just remember what the first speaker told, there's a lot of neurobiological underpinnings in both CD and ODD, so which could probably explain the non-response. So we need to be open for biological explanation, psychological and social as well. So this is the overall approach that we use when we work with children using non-pharmacological approach. So yeah, with the video, please. Yeah, please play. All of you closely observe and try to answer in your minds these questions.
Patience. Mama, I'm wondering, I just want We'll do it this way, do the right way. Why did you so long? What made you not, Mama? You'll be calm. Because right now,
Yeah, please pause. Pause. Yeah. Yeah. So did the mother enjoy the activity with the child? Yeah. Why is that? Mother was busy with the phone. Okay. Does this often happen in our homes as well? No, I'm not talking about the phone per se, that is there, but I think parents don't enjoy the activities with their children. Okay. So that's very important before we introduce any sort of a reward punishment paradigm, which we, often, talk about. So this is the first thing that we need to understand. Again, this comes from a very important theoretical background of the attachment theory. Then, if you see the mother, at the outright, she gave instruction, you do, particular manner. So this is where the child's lead is lost. Okay. We don't have the, awareness and patience to observe what the child wants to do and to encourage the child's leads. Okay. So picking up this child's lead is again something that we can talk, for hours. But if you don't do it, if you don't demonstrate, model for yourself as well as for your clients, I don't think it is going to work. So more and more practice is required. So what we did, it can be done in your clinics also, where we can give moment to moment feedback to the family that comes to you. Then was there any praise for the child? So it's very sad. So I think she completed the whole puzzle, but still there was no praise. So we need to practice praising children, and it should not be just like good shabash. That's okay in compared to not praising, but you should be specific. Say for example, in this child, a specific praise could be, you have done a nice cow puzzle. It was excellent. You put the head first, and then it was easy for you to put the rest of the body parts. So some sort of specific to the effort that the child has done, so that praise again should be practiced more and more often. Okay. So according to now the participants, can someone give some insights into what this parent child dyad can do to improve the relationship?
Active participation of
What
parent.
do you mean by active participation?
Yes, sir. For example, they say, let us do this puzzle, not you do this puzzle. They say, let us do this puzzle.
Let us do this puzzle.
Yes.
Yeah, very nice. Yeah, fine. That's good one. Let us do. The us part can come into collaborative framework. Again, it depends upon the cases. Some cases we might have to let the child do. In some cases, we might have to go for a collaborative approach. That's very good. Any other way in which we can improve the relationship? Yeah, again, we are vague. What do you mean by active involvement? Because I think definitely you will use 100 times active involvement in your clinics. Parents will, definitely 100% of the time, they won't understand what is active involvement. So that's where I think being little bit specific, getting into the language of the family, language of the child, and probably spending some time with the child to understand with the dyad. These are all some of the small things that without fail it should be done. Remember that we are handling child with externalizing problems, and there is tons of complaints in the minds of the mother. So praise, all these things are probably absent for many days to months together in the family. So this forms a very important initial first step. So I had the second question, but we will skip that due to lack of time. So we need to practice praising. We need to practice to reflect. What I mean by reflect is that you put the cow puzzle. As the child was, trying to fix the head of the cow, the mother will give a commentary, in a supportive language. So we need to practice that, reflecting the child's actions, the child's thoughts, emotions, if possible, if the child is verbalizing. Imitate, try to imitate what the child is doing, then describe and enjoy the activity. So these steps are basically taken from evidence-based intervention called PCIT. As I mentioned, we practice eclectic. We try to draw from various different theoretical models. If you have the resources to practice the full package of PCIT, that's good enough. Okay. So, but I have drawn the first part of PCIT, where we are trying to improve the connect with the child. So this some programs call it as special time. So this slide I have plugged it in just to break the monotony. These are some of the common principles of any programs that you take. Okay, so consequences should be immediate, specific, and consistent. Again, if you see the first principle, it's more about consequences, some sort of response cost and things like that, which is very important, but not at the cost of relationship the attachment of the child. So just consequences and punishment, that behaviorism part of principles will be very transactional in nature. Then other things involve parent to be calm and firm, not to be angry. And some of the other important principles, parent always delivers the consequences she says she will deliver. Increasing warm, positive interaction between parent and children is central goal of treatment. So if you can just go through this slide, it has a component of both behavioral, some sort of cognitive, some attachment theories. So if you're able to implement this principle in whatever form that is possible in your considering your local resources, that will be good enough. Now we will just quickly do the activity number 2. All of them pull out your small notepads that the organizers have given you, and make a table like this. We have probably 2 minutes maybe. Try to fill it up exactly in this could you table format basically. So the first cell has a positive behavior expected. So try to imagine the last child that you had seen, whether in your clinic. If there are parent here, you can just imagine your own child. When was the last time you had problems with your child in terms of compliance? And imagine and just try to fill it up quickly.
Sir.
There's a minute.
We're short of time. We're already 15 or 20 minutes late in this.
So we will end.
Yes, please.
Thank you.
Actually, it needs a full day workshop to do all these activities. So in fact, I think Dr. Karan, we have people, we should do a full day workshop on these things because these need a lot of time. Dr. Hina, please.
The case vignettes and discussions added great practical value and encouraged thoughtful reflection on real-world challenges we encounter in our clinical practices. As we conclude, let's carry forward the key message that early identification, empathetic understanding, and collaborative interventions can make a lasting difference in the lives of these children. On behalf of the organizing committee, I express sincere gratitude to our speakers, Dr. Sayed Karar sir, Dr. Vinayak Upade sir, and Dr. Sudeshwara sir. I would also like to extend my heartfelt gratitude to our chairpersons, Dr. Zaid Ahmedwani sir and Dr. Sujit Sarkhel sir, and to all the participants for making this session truly meaningful. Thank you all once again for your presence and participation. I now call Dr. Sabha and Dr. Harshvi to kindly take over.
Thank you, ma'am, and respected speakers for an enlightening workshop. We now kindly request our chairpersons to felicitate our speakers. Dr. Saeed Karar, sir. Dr. Vinayak, sir. Dr. Sideshwara, sir. Thank you, sir. We now request Dr. Savita ma'am to kindly felicitate our chairpersons, Dr. Zaid, sir, and Dr. Sujit, sir. Sujit, Sarkhel, sir. Dr. Sujit, Sarkhel, sir. And 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 Dr We also request ma'am. We also request ma'am to kindly felicitate our moderator, Dr. Hina ma'am. Thank you, ma'am.
Thank you, sir. Thank you, ma'am. Our next presentation explore one of the most fascinating intersection in psychiatry, the dialogue between mind and the body. The concept of mind-body dualism had shaped the medical throughout our generation. And in modern psychiatry, somatization stands as its living reflection, where the body speaks the language of the mind.
With that thought, let us delve into the presentation on somatization and mind-body dualism, which promises to blend history, philosophy, and clinical relevance into one enlightening discussion.
We are honored to have with us Dr. Rakesh Panal, sir, President of Jammu and Kashmir Psychiatry Society, a respected clinician and an accomplished academician. As the chairperson for this session, sir is known for his clinical excellence, compassionate approach, and deep commitment to advancing the mental health care in the region. We extend a very warm welcome to you, sir, and it's our privilege to have you chair this session for today.
Now, I have the privilege of inviting a distinguished academician and an inspiring leader in Indian psychiatry, Dr. Arun Marwale, sir, Professor of Psychiatry and the Secretary General of the Indian Association of Private Psychiatry. Sir has been instrumental.
He has not come.
Now I request a distinguished academician, Dr. Manu Arora, sir, heading the Department of Psychiatry at GNC Jammu. Sir has been instrumental in shaping the psychiatric education, clinical research, and professional association across the region. Sir, please join me in extending a very warm welcome to sir to chair the upcoming session and introduce our speaker for the session.
So welcome Dr. O.P. Singh, our friend, teacher. He has been editor of Indian Journal of Psychiatry for 6 years, 2018 to 2024, has more than 100 publications, is involved in a lot of research, teaching of undergraduate and postgraduate, and been an inspiring force for most of us. And among few of the things which have been written, which is difficult, but I'll invite you to start and hope to have wonderful interactions with you thereafter. Please start, sir.
Thank you, Chairperson, sir, for kind introduction. First off, I must say my thanks to the Jkcips Psychiatric Society for inviting me and these beautiful surroundings with beautiful people. Regarding psychiatry, all the debate which is going on, please slides. Sorry. Slide changer also. Okay, thank you. So there is a lot of debate going on, which is currently focused on this basically somatization and whatever we call this is the current. In fact, we have been trying to define it, redefine it, and succeeding, changing, again changing, and we find where to put it, all these disorders. We know that distressing and burdensome somatic symptoms are very, very common. Whatever the data says, but we find in clinical practice is almost 30% patients are having some kind of somatic problems. I will not clarify. Basically, I will be talking much of conceptual issues and practical issues than nitpicking the exact kind of classification. So the classifying them has been challenging, and every time every classification nosology has been changing. And that explains that we are not sure where we are. And ICD-11 has put it body distress disorder. So the classification, and we know that prevalence is very high, but no survey, no mental health surveys has tried to put that in kind of, in surveys, this disorder has been not been put because of the lack of operational guidelines. Though very recent article in 2025 in World Psychiatry, after ICD-11 has tried to quantify it with instruments which are current, and they have found around 2.8 to 3.5% of the people are suffering from these disorders, which is much higher than what we think for our schizophrenia or other things. So we need to learn to understand these disorders and manage them. Again, I will slightly show that if we know that WHO has said that to prevent morbidity and mortality from non-communicable diseases, you have to promote mental health. So while talking about somatic disorders, we can go to the previous concept of Alexander of kind of psychosomatics. So all the cardiac disorders, diabetes, they have psychological component and present physically. So how they differ from two so-called true psychiatric disorders or somatization disorders. Back pain, musculoskeletal disorder, I will be talking about fibromyalgia and IBS, though they are not classified with us, but the etiology, management, and everything is almost same with other our somatization disorders. So there is just change of wording, and different disciplines have been using different kind of operational criterias, but perhaps the core features has been same. So Hawaii physical presentation. In 2024, particularly in workplace, people have said that denial of mental health issues, we cannot say that we cannot get leave that I'm not feeling well mentally, but we can get leave if we say that we are not feeling well physically. We have having back pain, and nobody can in fact rule out a back pain. So if somebody says that I have been back pain, I get leave. If I say that I'm not feeling well, not feel like working, I'm not getting leave. I'm not getting relief from my duties. So we have to go in terms of kind of some physical disorder. Of course, stigma is there, and lack of support to mental health issues in all the organization, starting from the family to the community and to the everywhere else. So if you understand why people present with somatic dysfunction disorder, so this and social factors. I will just go with three cases to just illustrate three personal cases which give the three facets of these somatization disorders. We saw a patient was middle-aged, 58 years old, and she said that, "Doctor, I have something wrong." And you are not able to diagnose. And she has been to different faculties, we examined, and everything was fine. And we insisted, no, you do not have nothing wrong, do not have anything wrong with you. But she insisted that no, I have something. Down the line, in 2 years, she developed subcortical dementia and ultimately dementia, and there is a lot of pain. So this is something which still haunts me, that we have kind of everything investigated. But probably she was correct, we were not correct. So while dealing with these patients, please keep in mind that there may be something which our understanding of the illness is not, the concept of medically unexplained symptoms, our concept may not be picking up, but there may be something happening there. So another is very known young girl of one of my friends, who was a kind of very senior medical representative, and she started to have respiratory distress in the morning, one day before her examinations. He took her to 4 cardiologists who could not find anything, and everybody assumed that because of examination she is having a kind of respiratory distress. So while she came to me, suddenly I saw that accessory muscles are moving, and one simple X-ray gave that whole lungs has become white, miliary tuberculosis. So there are sometimes we are presuming a lot of things. Young female presenting with respiratory distress, cardiac pain, we automatically assume that this is something to do with stress. So again, army man's widow with functional neurological disorder. So again, I just want to emphasize the cause and other things. So she came with father-in-law. Father-in-law is not allowing her to talk with me alone. And we have again presumed that husband has been killed in action. So she must be having depression and she must be having physical kind of conversion disorder. But then she said, no, that is one reason. But what is happening is that father-in-law, who is a reputed headmaster of that area, was having sex with her, and mother-in-law will keep guard. The reason being that if this is there, she may go to other person. She is young, so she should be satisfied. So again, the thing is that what we presume to be the cause may not be the cause. What I say, we must reach the third layer of truth. First layer of truth they will give, but we have to reach like Agatha Christie to third layer of truth to help these patients. So relearning is required, how we talk, how we frame. I'm not going to go into the philosophical implication of the mind-body dualism, because one of my topic is mind-body dualism. So I have to talk, which is this sort of reason why all these things are happening. So please say 10 minutes before, please let me want. So we know that Descartes gave the mind-body dualism. And at that time, it was kind of revolutionary. What happened that before that, the Christianity said that all human beings are kind of a spiritual being, and all other things are spiritual. So we get ill because of the sins and all those things, and dissection was prohibited. We cannot dissect, we cannot do anything. So he came out with this mind-body dualism. The mind is spiritual, body is kind of not spiritual, the body is material. So that led to whole kind of development, what we call modern medicine. People can kind of experiment with the body. People can give bodily treatments, so-called somatic treatments. We know that we call them somatic treatment. That treatment geared to the body. But he kept mind out of this. So mind is something again remain spiritual. And that lead to kind of, though our other faculties developed, the mind or psychiatry remained at the same plane, which remained at spiritual, and development of stigma and all those issues, and all those today we are fighting that both are same, both are different, whether brain is there or whether mind is there. All these things basically started because of this thing. While mind-body dualism led to development of modern medicine, at the same time, it sort of hampered development of modern psychiatry. And still, our terminology, the things we talk, still reflect all those things. When we talk, said, नहीं नहीं ये वो ऊपर है, हाँ, physician said that कि वो ऊपर वाले, उसका जो problem है ना ऊपर वाले में, you do not have any problem, you have problem here, as if that is not there. And in our psychiatry department, it was upper floor from medicine. They will say कि तुम्हारा ऊपर वाला problem है, ऊपर की ओर जाओ. So these all the terminology is still. So we need to relearn how we talk about this disorder and how to phrase them. So somatoform disorder have been orphan child. Neither psychiatrists nor physicians have taken it seriously. Physician, though prevalence very high, so they will not come to psychiatrists or mental hospitals. Or if you come to mental hospitals, psychiatrists were too busy care for what we call severe mental disorders, mania, schizophrenia, to pay attention to these people. These people are kind of bothersome for psychiatrists also, or for physician. Oh, itna test kar liya, kuch nahi milta hai, ye, you should not come to us, go to psychiatrist. So they became, in fact, orphan child where nobody was willing to spend time with them and manage them. We know that it started with Briquet syndrome, Paul Briquet. And so basic criteria has been that they feel sick, they seek help. Whatever consultation you do, still they feel that they are ill, and they continue to seek medical care in spite of reassurance and all those things. And this term was given by Steckel. We know that slightly mispronounced, a German term, where they say basically somatic praxis means the language of the body, which ultimately body talk and which become somatization. So they are basically exclusive physical symptoms despite demonstrable psychological problems or emotional distress. Worried that they have physical illnesses, frequent unexplained symptoms which lead to help-seeking behavior. Kirmayr and Lipewski has done a lot of work on this. So basically, tendency to experience and communicate somatic distress, psychological distress as somatic distress. Any symptoms unaccounted for by pathological findings, to attribute them to physical illness and to seek medical help for them. This has been termed, we try to be more scientific. And in spite of somatization, we started using because medically unexplained symptoms. So the terminology itself says all. Who cannot explain? It is the patients who are not able to explain, or we are not able to explain. So though we put the burden on the patients, actually it is a burden on us. The name itself says that there are medically unexplained symptoms. So we are not able to explain. In the future, maybe we are able to explain. So I'm slightly taking it more forward and slightly broader. I am talking about groups of medically unexplained symptoms, which are traditionally not classified into the rubric of psychiatric disorders or somatization, like IBS. So irritable bowel syndrome, nothing is being found. Presumed there is psychological distress. Then fibromyalgia. I was very, very astonished that we learned that fibromyalgia, we need some tender points and all those, some demonstrable signs. But now the kind of Rheumatological Society of America has come out with diagnostic criteria where they are checklist that you have pain in 4 sites. You do not have to demonstrate that are tender. So how it is different from kind of our concept of classical somatization? It is same. They are also doing patients complain that 5 sites, 6 sites. So that's all for diagnosis. No demonstrable tenderness, not demonstrable, no increase of CRP, no increase of any other thing. So that is not required. So how it is different? So we know that they have been prescribed every antidepressant, antipsychotics, but when they come to us, but we have to treat them and make them better. So DSM-5 and ICD-10, DSM came with somatic symptom disorder, conversion disorder, illness anxiety disorder, so-called the hypochondriasis.
Sorry, sir, just 10 minutes left.
Okay, vexatious disorder. And now the ICD-11 has come with body dyslexia disorder. Again, the concept slightly has been changed. Like now they are not saying that there should not be any physical disorder. It is only that the concern and help-seeking behavior should be more than what the physical symptoms warrant. So it is again, we are again changed the concept. I'm not going to etiology. Again, there are two kinds of top-down, where central centers are active, and we have more pain perception. From bottom up, that more perceptions changes the brain. And there are some areas, particularly frontal gyrus, anterior cingulate gyrus, the insula, and the posterior cingulate gyrus. All these are involved, and central sensitization may have been an underlying factor. But again, I will talk with family and environment. Childhood adversity raised the odds of developing bodily distress by 4 fields. Childhood sexual abuse increases the chance of cardiac mortality by 3-fold. So these things are, there is some common mechanism. Household work, particularly if considered burdensome, with a women have this. Because household is so much boring and less rewarding. And what is important is economic control and dependence. It is not that economic kind of, for every study, there is not the resources, but inequality of resources which is being talked about. So who controls the resources? I jokingly say that if daughter-in-law comes with headache, that means she belongs to a traditional family or business family where mother-in-law controls the resources. So she has pain. And if the mother-in-law comes with headache, that means the son is working and having salary where daughter-in-law controls the money. So these things are very important. And being in recessive position, people say that the language is important. They cannot express their distress. It is not so, because all the traditional societies are very, very well in expressing language. What is important that the dominance, they cannot express their feeling. That's why culture-bound syndromes and others, British were ruling us. So we cannot express anything rather than physical feeling. So that lead to this. It is not that our language was not there to express that feeling. Fatigue syndrome. Chronic fatigue, though postulated, was not associated with the hemoglobin level. Interestingly, socioeconomic deprivation, poor education, being in debt, being experienced hunger in the recent past, and gender disadvantage. Widowhood, oppressive restrictions of women's life, lack of a trusting relationship with a spouse, violence, poor mental health. These things were associated with chronic fatigue syndrome more than the hemoglobin. And we must have heard of idiom distress when they want to talk, and so that they can get help outside the family. So I worked in a health center for 3-4 years. And every day, there were a lot of widows working, 70 years, 60 years female, who will come religiously every 3 days for their check of blood pressure and others. And why it was so? Because that gave them an opportunity to interact with other people. That was their day out. Hospital was something for which they used to come. And they talk, they will chat from 9 a.m. to 2 p.m. and then go home. So these are the things which are factors. I was talking a story of headaches. So who is your headache? And similarly, who is your heartache? So rather than where it is your headache or where it isn't. So gas, engine, etc. because gas is humbling. In West Bengal, Dr. Sanjeev Jain is sitting, is making a lot of jokes about kind of people in West Bengal. But for people in West Bengal, everything is gas. Even if they have a heart attack, they are having gas. So, so all those things are there. So Ginjini, basically, food, nutrition are other dimensions. So these sensations are there, Dhat syndrome, all these things are basically how we express our idioms. General principles of treatment is that we should take complaints seriously, full attention given to the patient, rapport, and do not reattribute much symptoms to the psychological causes. Don't say that these are all being due to only psychological causes. Say that psychological causes are making it worse, making it more, because then it is much more acceptable. Context factors as amplifier rather than causative. Say that they are amplifying, they are not causative. Symptomatic relief, antidepressants, management options are there. As per textbooks, somatization disorder is one of the most difficult things to treat. But what we get as in our patients are very easy to treat. So there should not be any nihilism. Psychoeducation, RAPO works as well as CBT. But we have to take into account patient understanding and others. Psychotherapists are working. Yoga and somatoform disorders, there are studies which has found useful from our own NIMHANS. I have already talked about fibromyalgia. Rheumatological Society now say that you do aerobic exercise for fibromyalgia. We are very kind of hesitant to say you do yoga, but they are saying do aerobic exercises. And pregabalin is now recommended by FDA, which again have different kind of actions. Pharmacotherapy, antidepressants are effective. We know that TCAs or SNRIs are more effective because they pain modulation they can control. If there is illness anxiety or hypochondriasis, which goes more to the kind of OCD spectrum and others, where SSRIs are more effective. There are other molecules, flupentixol and miltefosine combination, which is used hugely and has been found very useful to treat this patient. Opiprol, duloxetine. Duloxetine is not known as antidepressant nowadays. Duloxetine is now a pain medication, exclusively prescribed by orthopedicians. So we know that it is a SNRI and it is an antidepressant. Dissociation conversion, I am not going into detail. Only thing I say that in our country, sometimes what we learn that secondary gain should be cut. Sometimes we should be slightly slow. The person, particularly females, are working so hard and they are not cope up with the amount of work they have to do. And if you cut the secondary gain, they will simply fall flat. So be very cautious about it. So physical examination is required and sorry. So we should understand that problem is not imaginary. Pain and distress are real, and we have to treat those patients and be empathic towards them. Do good physical examination and be very kind of provide attention to them. With this, thank you so much.
Thank you, sir, for a wonderful presentation. The house is now open for a very short and qualitative discussion. Anybody? Okay. So basically, mind and body can't be separated. This is the thing. Just a few days back, I had a conference on diabetes. And when we know that every one person in 4 in diabetes is going to have depression, and the diabetes distress is around 44%. The compliance and the blood sugar level will never be controlled till we address that issue. So we treat not disease, we treat human with disease. So this is the concept, mind and body are the same, both need their treatment. Thank you, sir. Thank you.
Just diabetes regarding that, already WHO and UN has said that sustainable goal is to reduce morbidity by NCD by promoting mental health, and ICMR has opened centers everywhere to promote this kind of thing. For diabetes, again, a lot of my friends are diabetologists. Whenever they are not able to control their blood sugar, though do not find any psychological disorder, they send their patients to me. And sometimes our medication help them to control the blood pressure and hypertension. Thank you. Thank you so much.
Thank you, sir, for that enlightening and thought-provoking presentation. It truly added depth to our understanding of the topic. Now, we kindly request our chairpersons, Dr. Rakesh Banal, sir, and Dr. Manu Arora, sir, to kindly felicitate our speaker. Thank you so much, sir. Now we request Professor Dr. Mushtaq Ahmed Margoob, sir, to kindly felicitate our chairperson, Dr. Rakesh Banal, sir, and Dr. Manu Arora, sir.
Thank you, sir. We'll now have a tea break. Please return to the hall by 10 minutes as we resume our inaugural ceremony.
बनाने का तो जो अभी हाँ उसी लिए ना हाँ पहले कॉफी पी लो हाँ
We request everyone to kindly return within 5 minutes for the inaugural ceremony. Thank you.
There are no videos like it.
We shall talk about you. We shall not carry the metaphor. आगे सोफा में adult and yours is adult. यहीं पे रखा हुआ है चेयरपर्सन वाला मुझे बाद में मिलेगा। ये अच्छे हैं, बहुत अच्छे हैं, बहुत अच्छे पेपर माची का काम है। They are very beautiful। और हमने स्टिकर ऐसा रखा है कि आपको घर में लगाना है तो स्टिकर मिल सकता है। फिर घर में तो लगाना ही पड़ेगा। इतना सुंदर है, दूसरे को दे रहे थे तो तभी लग रहा था कि हमको भी मिलेगा। Such a beautiful। No, everything aesthetic is simply out of the and I know that. नहीं sir, ये तो सब लोग इस कॉन्फ्रेंस कितनी मतलब अरे से ठीक है। यस बोल ही दे रहे हैं कि सबको थोड़ा सा पकड़ के करवाना वाले लोग कोर्ट लगते नहीं हैं। ऑनलाइन हाँ तो सबको थोड़ा बोल दे मे नॉट गिव मी बट गिव मिलेगा तो मुझे मिलेगा। ऑल द बेस्ट। अभय मत कर रहे हैं सर। हाँ तूफान पत्नी है छोटी है ऑफिशियली। तूफान पत्नी का वो पोजीशन मत कर। ओके सर वो राजू साहब ने क्या अप्रूवल लिखा है 2015 में ही अप्रूवल हुआ था। हो गया वो क्या हुआ है आप सपोज कर लो। Dr. Raju posted it into pixel conference display। फर्स्ट कॉन्फ्रेंस 2015 में अप्रूव हुआ था, पहला कॉन्फ्रेंस 25 में हो रहा है। वेल ऑर्गेनाइज्ड। Just assume that it's ठीक है। If I win, I will give 4,000 people take the reference देते हैं because done। Just लेटर कर देंगे 2015 में हो गया था, वो लेटर नहीं मिल रहा है, हम नया लेटर इशू करेंगे। No need to go through all these। है तो अगर मतलब यहाँ पे आप सबको देख लेना कि बहुत बड़े अब आपके लिए खत्म हो गया तो एकदम and they are have all the characteristic of that। They know the system को they know to manipulate our they know how to manipulate the system। ना दिन तक वो सिस्टम में अभी तो इतना उसके लिए लगता है ना, नहीं तो दूसरा आदमी छोड़ देता है। नहीं बाकी जगह ये तो सिस्टम को ऐसे चलाते रहते हैं ना, इनको तोड़ना requires lot of hard work which you have done, otherwise तो नहीं होता। आप 3 बजे 4 बजे निकलेंगे। उसको आपने फोन किया ना? 4 बजे करीब जाके लेके मैंने सब पैक करके रखा हुआ है। इवन होटल आई कैन दे कैन चेक मी आउट if they want. Luggage is all packed.
गुड आफ्टरनून सर।
गुड आफ्टरनून।
कैसे हैं सर?
क्या खबर है?
बस बढ़िया सर। आपका एक सेशन और हो गया सर?
हाँ जी,
अभी पोस्ट लंच भी है ना? एक
पोस्ट लंच भी है, चेयर है, स्पीच हो गया, खा लिया, फिर आज लौट जाएंगे।
आज ही डॉक्टर सर कितने बजे सर?
6:55 की फ्लाइट।
हमारा दिल्ली होगा ना सर? कोलकाता?
कल डायरेक्ट थी, उसको चंडीगढ़ में
ओपिंग फ्लाइट
वो मैंने चेंज नहीं करना पड़ेगा।
ओपिंग कल आए सर आप? फाइनल
रैपिंग अप ठीक है,
बहुत अच्छा काफी अच्छा है रिस्पॉन्स।
सबको बोलते रहना है।
नहीं मैंने बोला ना आपको सर रिस्पॉन्स
उनको बोलना है कि देखिए आपने जीता है, तो वो क्या होता है ना, आप लोगों से बहुत लोग बात करते हैं ना,
नहीं सर सभी बोल रहे हैं लाइक वी डोंट आस्क वी गेट दिस रिस्पॉन्स सर। ठीक है सर,
थैंक सिलगुड़ी आना पड़ा, उससे मिलना पड़ा। बट आपने जो एनकरेज very okay, already it's a good start, very good. बहुत रजिस्ट्रेशन है मैम, 400 रजिस्ट्रेशन सब जगह से। देखो फ्रॉम ये सारे पूरे लेफ्ट ऑफ कंट्री सब जगह से आए। It is very participatory kind of thing. बिल्कुल। नहीं बहुत बढ़िया। अब गर्मी लगने लगी। हेलो सर बॉस क्या हो रहा है? कब आए? तो साहब नहीं आज तो चले जाएंगे सर। अच्छा लोग हैं ना वो तो हमारे यहाँ से टाइम का इतना प्रॉब्लम है। हेलो
आपने एक और बच्चे को जरूर दे दिया, देखिए।
हाँ
है ना? अभी आपको देखकर तो ये विचार आया कि जंग नहीं है बाप, है ना?
दिस इज वेरी ग्रैंड।
हाँ, अच्छा है।
इतना अच्छे से किया इन्होंने। हेलो even I came across treatment support for the election कर रहा हूँ फोन तो एक बार फोन ये लोग
क्या बात है बॉस, क्या चल रहा है?
फॉग चल रहा
फॉग तो अच्छा, इधर तो ज्यादा ही था सवेरे।
है कह रहे वो एडवर्टाइजमेंट वाला फॉग चल रहा है।
एडवर्टीजमेंट वाला, बॉर्डर वाला। और सब ठीक है, फैमिली ठीक है?
नॉमिनेशन मेरा कैंसिल करने की कोशिश क्या हुआ
इसमें
तुम्हारे दोस्त भास्कर ने और बाकी लोगों ने बिना बात का कंट्रोवर्सी यार, सबका देखो सबका खराब लगता है ना। कॉन्फ्रेंस में दारू पी रहे हैं, अगर हम फोटो पोस्ट करेंगे सबका इट लुक्स नाइस। ही हैज बीन ड्रिंकिंग 15,000 रुपीस पर कॉन्फ्रेंस। एक बॉटल का दाम तो 5
Nobody
स्टार
had reservation.
कोई बात नहीं है ना।
It's okay because everybody does it.
उसको लेकिन अगर किसी का
कहते हैं ना, इस हमाम में हम सारे नंगे
सब
हैं।
में
That is absolutely correct.
बिना बात का दूसरों के हाथ में क्यों आप हथियार दे रहे हो? यू आर गिविंग
Weapon to the people.
Good afternoon to everybody. I would request everybody to be seated as we will soon begin to kickstart the formal inauguration. इसका मेरा कोई काम नहीं है. Requesting all the esteemed guests to be seated, please, so that we can start the inauguration ceremony. अब मैं जो बोलती हूँ वही करते हैं. Assalamu alaikum and a very good afternoon to the respected dignitaries, esteemed guests, dear colleagues and friends. I am Dr. Ikra, a senior resident in Department of Psychiatry, GMC Srinagar. And it gives me immense pleasure and honor to welcome you all to this landmark occasion of the first national conference of the Jammu and Kashmir Psychiatric Society 2025 being held at the Sher-e-Kashmir International Convention Center, nestled between the serene Dal Lake and under the calm gaze of Zabarwan Hills. There couldn't have been a more fitting setting for this event, a place that embodies both reflection and resilience, much like the profession itself. Psychiatry, after all,
is about finding strength amidst the fragility, light amidst the darkness, and meaning amidst uncertainty. As we all assemble here, I'm reminded of a couplet by Faiz Ahmed Faiz, which says, दिल ना उम्मीद ही तो नहीं ना दिल ना उम्मीद तो नहीं नाकाम ही तो है लंबी है गम की शाम मगर शाम ही तो है. It reminds us that even in our longest nights, the promise of healing and renewal remain. The theme for this conference is Echoes of the Past and Hopes for the Future, which beautifully encaptures the essence. It reminds us to honor the timeless wisdom of our mentors, pioneers, whose work continues to echo through every consultation, every classroom, and every act of empathy that we offer to our patients today. At the same time, it invites us to look ahead, to envision a future where mental health is destigmatized, is more accessible, and compassion and science will walk hand in hand. This conference marks a milestone in the journey of J&K Psychiatric Society, a society that has grown steadily through dedication, scholarship, and collective spirit. Today, as we join hands with the Indian Psychiatry Society, we stand proud to host the colleagues and mentors from across the nation in this celebration of knowledge and collaboration. We are deeply honored to have with us an industrious and illustrious gathering of stalwarts whose presence has elevated the occasion. I consider it my utmost honor and privilege to invite on stage with a huge round of applause Dr. Rakesh Banal sir, Honorable President of Jammu Kashmir Psychiatry Society, who will be accompanying our chief guest and President of Indian Psychiatry Society, Dr. Savita Malhotra ma'am. Please, huge round of applause for both of them. I would also request Dr. Yasir sir, General Secretary, Jammu Kashmir Psychiatry Society, to kindly come on the stage and accompany President-elect Indian Psychiatry Society, Dr. T.S.S. Rao sir. Requesting Dr. Mansoor sir, the Vice President, Jammu Kashmir Psychiatric Society, to accompany Dr. Sujit Sarkhel sir, Honorable Editor, Indian Psychiatry Society, with a huge round of applause. I would also like to welcome on stage Dr. Sheikh Javed sir, Coordinator, Jammu Kashmir Psychiatry Society, Dr. Nizamuddin sir, Treasurer, Jammu Kashmir Psychiatry Society, Dr. Majid Shafi sir, Joint Secretary from Kashmir Division, Dr. Akhil Mania sir, Joint Secretary from Jammu Division, Dr. Sabrina Kadri ma'am, Editor, Jammu Kashmir Psychiatry Society, and Dr. Karar sir, Member Coordinator with Indian Association of Child and Adolescent Mental Health. Do we have Dr. Karar sir here? Dr. Nizamuddin sir, are you here? Moving on, I'd like to request Dr. Rakesh sir, Honorable President, Jammu Kashmir Psychiatry Society, to please come forward and felicitate Dr. Savita Malhotra ma'am, President of Indian Psychiatry Society. Requesting Dr. Yasir sir, General Secretary, Jammu Kashmir Psychiatry Society, to kindly felicitate President-elect IPS, Dr. T.S.S. Rao sir. requesting Dr. Mansoor Sir, Vice President JK Psychiatry Society, to please come forward and felicitate Dr. Sujit Sarkale Sir, Honorable Editor, Indian Psychiatry Society. Thank you so much. While we are at the felicitations, I would humbly request Savita Ma'am, President, Indian Psychiatry Society, to kindly felicitate our President, JK Psychiatry Society, Dr. Rakesh Sir. Ma'am, if you could take a moment to also felicitate our General Secretary, Dr. Yasir Sir. And Vice President, Dr. Manzoor Sir. Ma'am, please. Thank you. I'd like to request TSS Rao Sir, President-elect IPS, to kindly felicitate Nizamuddin Sir, Treasurer. Dr. Sheikh Javed Sir, Coordinator, Jammu Kashmir Psychiatry Society. Dr. Karar Sir, Member Coordinator for ICAM. And Dr. Akhil Mania Sir, the Joint Secretary from, the Joint Secretary from Jammu Division, sorry. Thank you, sir. I would request Dr. Sujit Sarkale Sir to kindly felicitate Dr. Sabrina Kadri, the editor Jkcips. And our Joint Secretary from Kashmir Division, Dr. Majid Shafi Sir. Sujit Sir, kindly. Thank you so much, sir. I'll also take a moment to request Dr. Savita ma'am, Dr. T.S.S. Rao sir, and Dr. Sujit sir to felicitate our patrons, Dr. Hamidullah Shah sir, Dr. Mushtaq Margoob sir, नहीं sir, so very Dr. Mushtaq Margoob sir on stage. Thank you. Dr. Jagdish Thapa sir, and Dr. U.K. Mehta sir. I don't think he's not here. Somebody please, one of you please keep it. Sir, Sir Kasubina. Thank you. Thank you so much. We'd also like the esteemed President-elect and editor to felicitate our advisors, Dr. G.A. Vani sir,
Except for Dr. Mehta.
Dr. Manu. Dr. Manu sir is accepting on behalf of Dr. U.K. Mehta sir. A big round of applause, please. And Dr. Majid sir. And Dr. Majid Shafi sir will accept on behalf of Dr. G.A. Vani sir. Dr. Junaid sir. Requesting Dr. Ejaz Ahmed Khan sir for felicitation by our esteemed members. I'd request Dr. Sadakat Rahman Rabu ma'am to kindly come on the stage for her felicitation. वो है?
I'd also like to request Dr. Muhammad Aslam sir to kindly come on the stage for his felicitation. Requesting Dr. Shaukat Ahmed Mir sir to kindly come on stage for his felicitation. If one of our esteemed members could come and receive on his behalf. Junaid sir. Ji sir, thank you sir. That's so nice of you sir. Thank you so much. A big round of applause for Dr. Abdul Majid sir, who's accepting the felicitation on behalf of Dr. Shaukat Ahmed Mir sir. Thank you. Last but not the least, we had one more felicitation, Dr. Amrit Patojoshi, Honorable Secretary, IPS, who unfortunately could not make it today because of some personal reasons. I would request Dr. Saida Rukshida ma'am to please come on the stage and accept the felicitation on his behalf. Thank you so much. A huge round of applause to all of you on the stage and everyone in the audience. Thank you so much. I would like to request Dr. Rakesh sir, Honorable President, Jammu Kashmir Psychiatry Society, to please grace the stage for the welcome address. Sir.
Good afternoon, dignitaries on the dais, esteemed guests, respected seniors, distinguished speakers, and my dear colleagues and friends. It gives me immense pleasure and pride to welcome you all to the inaugural ceremony of the first ever Jammu and Kashmir Conference of Indian Psychiatry Society, Jkcips 2025. This is a truly historic event for all of us. For the very first time, the fraternity of psychiatrists from Jammu and Kashmir has come together to host a national level academic event of this magnitude. It fills my heart with great joy to see this dream take shape, a dream that many of us have shared for years. This conference is not just an event, it's a celebration, our collective growth, our shared aspirations, and our belief that the Jammu and Kashmir has much to contribute to the field of psychiatry. I want to begin by expressing my deepest gratitude to every member of the Jammu and Kashmir Psychiatry Society who worked tirelessly to make this possible. Your dedication, hard work, and sense of purpose has been nothing short of inspiring. A very special word of thanks also goes to our patrons, the senior members whose wisdom, guidance, encouragement has been our greatest strength. Sir, you have been our mentors, our anchors, and our true strength. Without your support, this event would not have been possible. I also extend my heartfelt thanks to the Indian Psychiatry Society for their constant support and collaboration. Their faith in our capabilities and their encouragement to hold this conference under their esteemed banner has truly meant a lot to us. We are deeply grateful for this partnership and we hope will continue to strengthen in years to come. Of course, no event of this scale is without small challenges. I would like to offer my sincere apologies for any inconvenience you may have faced during your stay or travel here in Srinagar. The weather, as you can already feel, is quite cold, colder perhaps than we anticipated, but I hope the warmth of our hospitality and our friendship and our shared purpose will make you feel enjoyable here. Once again, thank you all from the bottom of my heart for your presence, your encouragement, and your belief in us. Welcome to JKPS 2025. Welcome to Srinagar, and welcome to the heart of Jammu and Kashmir Psychiatry, where even the coldest weather, the warmth of our fraternity shines bright. Thank you.
Thank you so much, sir. I would also now like to request our General Secretary, Jammu Kashmir Psychiatry Society, Dr. Yasir Hassan Ratha, to kindly come on the stage, sir, and please deliver a few words.
Respected Chief Guest, President IPS, Professor Savita Malhotra, Vice President, Professor T.S. Roy, Editor IPS, Professor Dr. Sujit Sarkher, esteemed dignitaries on and off the dais, distinguished faculty, dear colleagues, friends and students, a very good morning to all of you. Good afternoon, in fact. Good afternoon to you. It gives me immense pleasure to stand before you as a General Secretary of the Society and as a organizing secretary of this conference, which is a historic event itself. This is the first ever annual conference of J&K Psychiatric Society organized in collaboration with IPS. Today is not merely the inauguration of the conference, it's the beginning of a new chapter in the history of psychiatry in J&K. When we first envisioned forming this society, it began with few energetic and committed minds who wanted to create a professional platform, an impactful and uniform platform, a society that works to connect every mental health professional under one umbrella, and also to create a body that represents every mental health professional, addresses their challenge, and brings new opportunities for them. Today, that vision has been achieved, and thanks to the collective and consistent effort, dedication, and goodwill of so many of you present over here. Madam, today, right now, we have around 144 members in our society, which will hopefully increase with coming times. We are deeply honored to have IPS as our partner in our first this conference. We all know IPS has been the torchbearer of mental health advocacy and scientific progress in our country over decades. And their guidance, support, and encouragement will be invaluable in nurturing our young society. We extend our heartfelt gratitude to IPS leadership for standing by us, for mentoring us, and for ensuring that voice of our society finds its rightful place in the national form of psychiatry. The vision we have envisaged, ma'am, for our society is already taking shape. our society will be conducting regular conferences and CMEs for academic exchange. And this conference is a stepping stone towards that achievement. We'll be providing opportunities to budding psychiatrists to represent the society at different national conferences. And I'm happy to share with you, ma'am, that recently 4 of our young psychiatrists represented our society in various national and regional conferences. We are in process of launching a full functional journal, which will be indexed. Hopefully, servers asking me about the indexing, the publisher. So it will be Science Direct. So hopefully we are in touch with them, and it will be launched. The cover paper will be launched today. E-copy of that will be launched today. We will be representing psychiatrists of J&K in every form to safeguard their rights. We'll be engaging with the government to strengthen mental health policies and budgets, and also to strengthen the mental health services across the districts and institutions. As organizing secretary, I take this opportunity to express my deepest appreciation to everyone who made this event and the society possible. To our mentors and senior mentors, to our patrons and senior mentors for their guidance and encouragement throughout this process. To the executive committee of JKPS for their tireless teamwork and enthusiasm. To our guest speakers who are present here, who have come from across the country to share their knowledge in this conference. And above all, to the organizing team, the silent heroes, who worked day and night to ensure every detail was in place. Thank you for your commitment and your spirit. In the end, I would like to say that every great journey begins with a single step, and today we have taken that step together. Thank you all.
Thank you very much, sir, for your insightful words. I'd like to request Dr. Javed, sir, the organizing secretary of this conference, to kindly come and speak a few words.
Good afternoon. On behalf of the organizing committee of Jkcips25 and office bearers of JKPS, we are all thankful to all members who are part of this watershed event of Jammu and Kashmir Psychiatric Society. This event has been possible due to the help of all office bearers of IPS and due to personal involvement and support of all JKPS members. JKPS has 144 members at present, and that number is likely to increase in future. We have already submitted our all documents to IPS office bearers for affiliation as JK chapter, and that affiliation letter is pending, and we request their personal intervention in this regard, so that we also become members, so that we also become part of mainstream psychiatry. We expect that the younger generation of JKPS members will take the society to newer heights in future. Thank you.
Thank you so much, sir. I'd like to request the IPS editor, Honorable IPS editor, Dr. Sujit Sarkhel, sir, to please come on the stage and deliver a few words.
Thank you very much for the privilege, and I'm really overwhelmed the way the conference has been arranged, the way the hospitality has been done, and way till now things are going at clockwork precision. I'm really happy to be here, and so also my co-office bearers, Savita ma'am, Rao sir, and on behalf of the entire national office bearers, I thank the entire office bearers of JK Psychiatric Society, the senior revered members, since taking names would take long time. I'm not taking individual names, and also the entire group of young psychiatrists and other residents, senior residents who have toiled day in and day out to make this happen. two names I would specifically like to take, not that that they are different, but just otherwise. Dr. Javed has been quite active in coordinating with the national body, and that actually needs a special mention. And another person who has been probably the main architect of the scientific program, but would always like to avoid the limelight. Big thank you to Dr. Arshad for having made such a flawless scientific program, having called luminaries in psychiatry from all across the country. My special good luck to Dr. Sabrina for having taken over. In fact, we did some preliminary talk. Scientific scholar who is also, which also is in charge of the ICMR and several other journals, is taking up, and I have assured Rao sir is there, ma'am is also there. We have assured our full logistic support to ensure that this particular work gets, I mean, this journal initiative gets indexed as soon as possible, and the research of this area is showcased worldwide. Thank you very much once again. Thank you.
Thank you so much, sir, for your kind words. I would like to request the President-elect TSS Rao, sir, to please grace the dais and speak a few words. Thank you so much, sir.
Good afternoon. I will speak a few words only because later Madam President would be speaking in great detail. Madam President and all the dignitaries on the dais and off the dais and all my friends. In the introduction, they were telling it is actually state conference or national conference, confusion. But from my point of view, it can comfortably be called as a national conference because down south to north, almost everybody who matters, they are here. I practice sexual medicine. I always say if you want to charge the battery, down south you have quite a few places, Kodaikanal, Ooty nearby, and Kashmir comes to our mind. When we were very young also, Kashmir Ki Kali and a lot of other movies, in fact, something extraordinary. And even though this is the third visit to this place, I am more than confident the way I am getting charged here, my wife would be really happy. Coming to Jammu and Kashmir, the hospitality is actually a very renowned one. And at least from the morning, at least 5 people asked me whether everything is fine and everything has been taken care of. To be frank with you, even quarter of this hospitality would have been more than happy. This is something more than what actually we were trying to look into. I am very happy that though it is a new branch, starting its what we call the initial journey, it looks like the way the conference has been organized and a lot of other activities which have been planned, that you are all veterans who are immensely capable of doing a great job. But one small this thing, in fact, in a one particular place, finding Rao, Sujit Sarkar, O.P. Singh, Nimesh, all who have worked for the journal is actually something very unusual. And I think you should take some advice from each one. And let me tell you, in fact, if you work properly with a little dedication and passion, everything is possible. We are having the what we call history of Indian Journal of Psychiatry, Indian Journal of Psychological Medicine, currently Psychiatric Spectrum Journal from IPS KC, and our own Journal of Psychosexual Health. Each of these things, almost 4, now they are in the index category. So a little bit of effort which is necessary. And the way it is going on, in fact, we always say to do something, motivation is necessary. What is possible, you do it. That means next minute you're already done more than what is actually expected. Add to that little bit of passion and maybe the attitude. In fact, you will be doing a wonderful, great job. Coming to Indian Psychiatric Society, Madam will be talking in great detail, except that from next year, there are 1 or 2, 3 agendas which are there. I just want to, what we call, trigger the ideas and need your help actually to go through. One is we are actually working on the idea that there should be central membership which actually percolates to zone and state, and for which almost quite significant work has happened, and Madam would be elaborating on that particular point. Second one, there are a lot of new emerging areas which actually need attention. I may be almost thinking about sex, but all said and done, so many newer therapies and so many new developments that are happening. Each one actually deserves attention, and that is one of the second area. Academics to look into. And third, of course, I love women. So beautiful you are. But all is said and done, I have decided that my cabinet to all the, so what you call task force to special sections will have minimum 30% of the ladies in that group. This is the promise, and I am sure that it will not be anywhere less than 30%. So with these few words, I am really overwhelmed by what all actually people have done for us. You have made a young man, and I'll be going back like a young man. Thank you so much.
Thank you so much, sir. Our chief guest and IPS President, Dr. Savita Malhotra ma'am, needs no introduction. Her contributions to the field of psychiatry span decades of exemplary service, research, and mentorship. She has not only shaped the academic and clinical landscape of psychiatry in India, but has also been a guiding force for countless young psychiatrists like myself who have been inspired by her dedication, industriousness, and clarity of vision. Her pioneering work in research, her leadership roles in both academia and administration have left an indelible mark on the discipline. We are truly privileged to have her here among us, and I would request ma'am to kindly grace the stage for her keynote address. Ma'am, please. A huge round of applause for Savita ma'am, please.
Thank you very much. Good afternoon, everyone. I bring greetings from the Indian Psychiatric Society. I am here in my capacity as the chief guest, but I must say that I am no guest. I am one among you. I am a member and I am a part of all of you, the JK Psychiatric Society, as well as Indian Psychiatric Society. President Dr. Rakesh Banal, Vice President Dr. Mansoor Ahmed, Secretary Dr. Yasir, I think you presented a beautiful summary and detail of the activities and the vision of this JK Psychiatric IPS chapter. I see the patriarchs of Jammu Kashmir psychiatry sitting in the front rows, Dr. Hamidullah Shah, Dr. Mushtaq Margoob, Dr. Thapa, and so many others. Then for this particular conference, the first conference of JK Psychiatric Society, the key architect, as has been said, is Dr. Arshad Hussain, sitting in the last row in one corner. And I was just wondering and trying to find out whether he's there in the audience or not, but there he is. Dr. Javed and Dr. Arshad, they have done tremendous amount of work in the last 1 year during my presidency time to revive and activate this JK Psychiatric Society. It was originally conceived in 2014, was approved in IPS, and then somewhere, I think in the paperwork, got lost, and then we kind of reactivated it, and there we are today in this conference. Apart from that is the team of organizers for this conference, Dr. Banal, Dr. Mansoor Ahmed, and so many others, everyone sitting on the desk. Invited speakers, participants, guests, delegates, and I acknowledge the presence of young students and the volunteers. Thank you very much. Thank you very much for organizing this conference and for this honor accorded to me to invite me as the chief guest. First conference, heartiest congratulations to you from me as a person, from Indian Psychiatric Society as a whole. So I think we are, this is a very, very important and occasion that the Jammu Kashmir psychiatry has come into a formal, formation. And see this at present, I am told that there are 144 members, and psychiatry, out of which there should be about how many in Jammu and how many in Srinagar? Maybe 30, 40 in Jammu and maybe 100 plus in Srinagar. That's the thing. And the most important thing is the presence of or representation of women in Kashmir psychiatry. Almost 1/3 of psychiatrists in Kashmir already are women psychiatrists. It's a great applause for them. It's another matter and maybe another time that when we will discuss and talk about whether women psychiatrists make better carers, better therapists, better healers, better organizers, better leaders, and so on. So the time will prove, and it will be kind of, we will talk about it later. Now, associations are important in many ways. It's very important that because it gives a platform for all the professionals to come together, and they come together for sharing, for learning, for socializing, for also kind of becoming a force and a strength for pursuing several other things, as a joint activity and organization to work with governments for policy and also for advocacy and so on. It's a way of empowering everyone, a way of creating a voice. Now, Jammu Kashmir is very important region in the country, not just because of the geopolitical reasons, but also because of the special conditions and circumstances it has suffered or it has experienced. Many professional societies in the past, they have actually held their conferences in Srinagar. They come here, and because Srinagar is such a beautiful destination and everyone in India wants to come here, but this is the first time that JK itself, it is holding its own conference, and that's a matter of great pleasure and applause. And this is, as has been said and is visible, is almost a kind of a national conference. We have representation of members, speakers, and delegates coming from the length and breadth of the country. Now, my experience with the Kashmir goes back to 2001, 25 years ago. 25 years ago, that was the peak of militancy at that time. At that time, Government of India, Ministry of Social Justice Empowerment, made a delegation of which I was a part, and members were from PGI Chandigarh and AIMS Delhi. And we were tasked to come here to Kashmir and create a system, a model, or a method to counsel the counselors of the trauma victims, the terrorism victims at that time. Trauma is a more, I think, lesser kind of a intensity word, but terrorism victims, the families and children of terror victims. At that time, the militancy was at its peak. And we came here right in this particular venue, Sher-e-Kashmir International Convention Center. That is where the meeting was held. And because this was the safest from the security point of view, and the only mental hospital or the institution that was there had already was burnt because of some fire some time ago. And that is where we we came here, and there was about 300 to 400 families, children, and counselors who were taking care of these, terror victims. And we all sat together, listened to their stories. Dr. Arshad at that time was, I think, a PG student or maybe a resident at that time. He was the one who presented to us some cases and case histories. And we sat here and listened to them. And it was, this experience had such a deep impression emotionally on me personally, and also all of us who were there, because the stories that were there, they were absolutely real and lifelike and gory, and so much of trauma and pain was kind of exhibited and there. And we who came as psychiatrists and psychologists from as a part of delegation, we had absolutely no words to of solace or reassurance. We could do nothing for them. All we did was allow catharsis, and we were hugging, and we were kind of there was so much of crying, and all of us, and we were just kind of holding each other's hands and hugging and sharing. So this was an extreme experience, I would say. And for the first time, these people had this the experience that somebody from outside had come from Kashmir. Kashmir was a totally locked kind of a place, and from outside, India was considered to be outside, and we were considered as Indians from outside anyways. And we came here, and they said that for the first time somebody has noticed us, has taken care of us, has come to listen to us, कि हमें कहीं से बाहर से हमारी खिड़की दरवाजा खुला है, हमें बाहर से हवा आई है, बाहर से रोशनी आई है. This is what we represented, a whiff of air and roshni. And this happened here. And of course, this was at that time the condition of Srinagar. I still have that vivid memory of all the buildings were burnt. They were all boulevard, these things. What boulevard? So this was along the Dal Lake. All the buildings were burnt, and there were bunkers, and there was army and security people with their guns pointing in alertness, full alertness. And we walked, and we were there in one of the small hotels there. And as we walked, we were the only ones. No one was there. We took a shikara ride. We was the only single shikara there. And then we were, after some time, maybe near Nehru Park or somewhere, we were stopped by the army. We couldn't go further. No, that was the state and condition of Kashmir in 2001 when we came. Of course, we submitted our report and everything to the ministry and government. I don't know what happened, but that is what it was in 2001. And I think the impression that, emotionally I was impacted so much that I felt very close immediately to Kashmiris, their pain and their discomfort. And thereafter, I think by some I would say destiny or something, that I was coming very regularly and repeatedly. Then I came for examinations, for MD exam. I came in 2004. Arshad was the first candidate. At that time, there were only 10 psychiatrists in Kashmir, 10 psychiatrists. And Srinagar had maybe 2 or 3. Dr. Mushtaq Saab was there, Dr. Hamidullah Shah was there. We had one, Dr. Abdul Ahad Beg from PGI, my senior alumnus, but he had passed away long back. So this was the state. And then thereafter, then I came in 2004, 5, and so on. So in 2002, we did a international conference on child psychiatry in Delhi, Ashok Hotel, and I was there. And so Dr. Mushtaq Saab sent his 2, 3, I think, PG students there in that first international conference. And then this was, and from there on, I have had a very regular contact and relationship with these group of people, Majid, Zaid Wani, Arshad, and so on. So this is how the story goes. But look at the situation now. The situation now, we already know how many people are there, and of course the things have changed considerably. And then I was here between 2010 to 2015, regularly coming, because we had started our telepsychiatry project. And this telepsychiatry project, Kashmir was, Srinagar was one of the sites. So Dr. Murgoob and then Makbul Dar, he's not here now. So they were the main coordinators and supporters who really worked very hard on this project. And we used to come and talk to patients, and we worked for about over 5 years after that. Now, other thing is, apart from terrorism, there has also been another major disaster. I mean, I'm recounting this because PGI was associated with these, things. There was an earthquake in 2005 in the northwest Kashmir of the magnitude of 7.6. That was, of course, the epicenter was in the POK, but our border area in Kashmir, Kargil area, that was very badly hit. And the team from PGI at that time was also again sent for trauma care, disaster care, and everything and so on. So from there on, I think the team of psychiatrists here, Dr. Mushtaq and all his students and other people have been consistently working in this area of disaster, trauma, terrorism, and working towards developing the intervention models, studying the nature of pathology and mental health morbidity that is seen in them. And Dr. Murgoob, still continues to do community service and till this date. And so this is absolutely exceptional and remarkable. Kashmir has tremendous amount of resilience, and they are very, very positive looking people, and lot of energy and desire to learn. I think when you meet with students and residents here, they are absolutely fantastic, brilliant, very keen to learn, very keen to engage themselves, and which is very, very, very good and very heartening and very important, and speaks well for future of psychiatry in J&K. Now, J&K chapter, now this is a kind of a new leaf in the calendar of JK activities. And now it's time to now, I think, focus on several areas which are of special interest and special importance, particularly for this area. Apart from rebuilding lives of people who have undergone trauma and faced disaster and so on, because this trauma, it does not end with ending life. It does not end. There is transgenerational kind of a continuation of trauma. And other things which I think are some of the special areas which JK, as a society, or because of the geopolitical system and place that it has some certain special or more specific or unique difficulties, problems, which have to be addressed. One of which, of course, is the mental health care delivery to people in the remotest and the farthest areas. It's a very difficult geographical area, and people are thinly spread far and wide. And to reach out to them it becomes very difficult. And so, but with this expansion of mental health care services and improvement in the manpower care, this number of psychiatrists, psychologists, I'm sure the things are going to improve and will be far better. Other thing I would say is, again, leveraging telepsychiatry would still be a very good method and approach. This telepsychiatry project did end in 2015-16 with my retirement, but certainly we have the modalities, methodologies, and systems still in place. And this can become a kind of a method to reach out to patients even in the farthest, remotest area. And Srinagar has been one of the sites where we have tested the feasibility and practicality of this system. So this, we would be very happy. I would be very happy to involve myself in the telepsychiatry system or services if these are to be planned. Other is, I would think, is that apart from, studying trauma and effects of disaster, is to focus on students, youth, children, and women. For society's betterment and mental health, is extremely important that we take care of the young generation, who is to kind of grow, develop, and become the future, adults, that they are provided the necessary care and protection, nurturance, and of all kinds, protection within family, within society, and so on. And then opportunities to learn, grow, develop, and have a good family system, have a good school education system. And so focus on children, focus on youth, young, the adolescents and students up to 20 years of age, and women. I think women are the ones, these children and women are the collateral damage in situations of war and situations of geopolitical crisis and so on. And they are the ones who majorly take the brunt, emotional, emotional brunt of the thing. And they still have the responsibility to continue to survive and take care of everyone still who's surviving. So I think they need tremendous amount of help and tremendous amount of mental health care. And that could be the another area where we could focus on. And I have already spoken on possibilities of studying trauma. Here there are generations and there are people. I think I would say Dr. Mushtaq Margoob can guide me and advise, is that maybe at least 2 to 3 generations together. And we could kind of carry out studies, and we could carry out not just population study, but also kind of more deeper biological studies and so on. So this could be the more specific and unique areas where we can work. But certainly, all said and done, we are extremely happy, grateful to all of you for organizing such a exceptional, conference. We all are aware of the hospitality, warmth, and care that the Kashmiris have always extended to us. And this is a very special and very large gathering. About 400 registrations for the first conference is very, very remarkable. And all our good wishes and congratulations to everybody who has organized this, who has envisioned this, and who have committed themselves now to work for psychiatry in the states of Jammu and Kashmir. Thank you very much. Thank you.
Thank you so much, ma'am, for setting such a thoughtful tone for the conference. As we formally inaugurate this historic conference, it is only fitting that we open it with a gesture that is deeply seated in our tradition, the lighting of Isband souls. In Kashmiri culture, the fragrant smoke of Isband symbolizes purity, protection, and blessings, warding off negativity and invoking peace and prosperity. Today, as we light Isband souls, we do not do so merely as a ritual, but as a reflection of our collective hope that this conference illuminates minds, inspires compassion, and strengthens our shared commitment towards the mental well-being. May the warmth and the fragrance of this light mark the formal inauguration of the first national conference of Jammu Kashmir Psychiatric Society. I request our dignitaries to kindly come forward for the lighting of Isband souls.
Sorry. Following the symbolic beginning, we now move forward to another milestone and proud moment for the Jammu Kashmir Psychiatric Society, which is the release of the Journal of Jammu Kashmir Psychiatric Society. This publication represents the intellectual heartbeat of our fraternity and is a platform to share research, reflection, and regional voices that enrich the Indian psychiatry. At the same time, we are also launching the first souvenir of the Journal of Psychiatry Society. And I would request Savita ma'am to also inaugurate the e-souvenir and journal. Right. Thank you. Thank you so much, ma'am. Thank you so much to all the dignitaries. As we draw this inaugural ceremony a close, it fills me with a sense of pride to witness the beginning of a journey that has brought all of us together. And for the closing remarks, expression of gratitude, I would like to request Dr. Mansoor sir, the organizing chairperson of this conference, to please grace the dais and say a few words. Following which, we'll all stand up for the national anthem. Thank you.
Respected dignitaries on the dais, honorable executive members of IPS and office bearers, distinguished guests, dear colleagues, good afternoon. It's truly an honor to stand before you and present a gratitude for your presence here. This Jkcips 2025 is another beginning. Although we began in 2014, but it took a while. But we have begun now, will not stop. I have a huge gratitude for all the people who have been involved in organizing this event as well as making JKPS functional again. My heartfelt gratitude to President Indian Psychiatric Society, Savita ma'am, for her patronage support throughout this conference for last 2-3 months. She has been in continuous touch with us. She has been helping us, patronizing us. My heartfelt gratitude to other office bearers, including President-elect Rao sir, Sujit Sarkhel sir. They have been there as our torch bearers. They have been helping us. They have been behind us to hold this event. My gratitude to our esteemed teachers, patrons, advisors who have accepted our all kind of, I'll say, demands. We demanded many things from them. Sir, aapko yahan rakhna hai, sir, aapko ye karna hai. They were all there. They did everything on a very short notice. They were very kind. A very huge applause and gratitude to the organizing committee. All of them. Many times we were a little harsh in our tone, but they were so gentle. Sir, hum kar lenge. It was 25 days once we started. It was 25 days only. They were all there. None of them had any kind of, I'll say, frown on their head, even if we were sometimes asking them to do an extra bit for us. Then a gratitude to all the people who are participating. We have people across the spectrum, from psychiatrists, non-psychiatrists. We have some enthusiastic students. We have people from other states. Then we have people from within the Union Territory, from all the areas. This is one, it's a JKPS, and it's a truly decentralized and democratic JKPS here. I see people coming from all the areas. Once you see the organizing committee in itself, it's very diverse. So since a lot of time has been already taken, I would say that I have a gratitude, but I want to come again and again for this gratitude. We want to see you again and again, maybe 2026, 27. Thank you all.
Thank you, sir. Thank you for your kind words and thank you for gracing the dais. I would like to request the dignitaries, the audience members to kindly stand up for the national anthem. Thank you so much to the esteemed dignitaries, wonderful audience. Thank you for your time, your patience, and may the spirit of learning and collaboration that filled the hall today continue to inspire the sessions ahead. We'll meet shortly after lunch. Thank you so much. कहाँ गई सब मेरे फोन से ले अब मैं क्या कर दिया मैं खाना खाना चाहती हूँ
जाने बहारा दिलम जाने करारा कुर्बान करे जान च गम नाच किनारा जाने बहारा दिलम जाने करारा कुर्बान करे जान च गम नाच किनारा तेरे नायक से कोई दस बशकारा तेरे बदन कोई नाम निसारा खुशदम से खुदारा 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 जिगर में बलता कलम जारा शम्स खुदारा 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 जिगर में बलता कलम जारा सिर उसने कदर दे हमें सहारा 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 में सहारा जाने वाला you can It's a bad corona. It's a hard corona. The camera suddenly flash corona. Nasarawa corona. मैं तो लोगों में दुनिया बस सहारा 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 में सहारा जाने बहारा 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 रुक चले सहारा जाने जाने बना अब इशारा करना फेंग कर दिया जिसान से जाना मोहब्बत जान लचो बोला बोल लचो मजना बबैत तो तस जाना अस्ताब तलाने सैनान सितारा 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 भाई सितारा जाने बहारा 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 लूट के चलो करारा करारा Sahara, 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 Julia, Sahara, लोलनारम सोलम सीने हा दिल बरो आर्म्योनी लोलना सोलम सीने हा दिल बरो आर्म्योनी शुस्से पत सिकम्युदी हा दिल बरो आर्म्योनी लोलना लोल शराब जुत में कलवान लोल शराब जुत में कलवान बस बड़ी बड़ी सूर्यंत प्यार मस बड़ी बड़ी सूर्यंत प्यार मुझ में साकी मुझ में साकी अमीरी नहीं हाँ दिल भरो आनंदी नहीं मुझसे मत सिकम्युदी नहीं हाँ दिल भरो आनंदी नहीं लोलनारो खंजर देश तलवार नस्त खंजर देश तलवार कन दूर वक्त चालन कन दूर वक्त चालन दुख बगजता Rangalanshi, Hadil Baro, Arjuni, Lolanar, Sol Musti, Hadil Baro, Arjuni, Hadil Baro, Arjuni, Hadil Baro, Arjuni.
बैड बॉय 59 कितना पिटवाएगा भाई।
के बैठना होगा
अबे ड्रॉर में
What the hell is this place?
The research facility for the original Jurassic Park. What the hell are those? These dinosaurs were too dangerous for the original park.
एक पैगाम दिया क्यों जयपुर से पैगाम आया क्या ये बात दिख रहा था ना जो आपकी बात
ये सारी ट्रेडिंग स्ट्रैटेजीज का बाप है। ये सारे सेगमेंट्स, सारे टाइम फ्रेम्स और सारे
अभी बोलोगी तो मुझे हमें निकलना है, अगर निकलना है तो क्यों निकलना है तो कहाँ निकलना है? बोलो वीडियो बंद कर।
वाइट कलर ये क्या है, क्या ये हैंग हो गया।
LIC युवा प्रोफेशनल्स के लिए लाए हैं नवजीवन श्री। करें नियमित प्रीमियम का भुगतान, जीवन बीमा का आनंद लें, प्राप्त करें प्रीमियम के प्रतिशत पर गारंटीकृत एडिशंस, अपने वित्तीय लक्ष्यों के अनुरूप मैच्योरिटी पर गारंटीकृत धनराशि पाएं। मौजूदा पॉलिसी धारकों के लिए आकर्षक अतिरिक्त लाभ आज ही खरीदें।
जल हमारी लाश जल पास करे तो पास करे पास करे तो आलमा देवा याद में बोल देवा याद में बोल फसल जाना याद में बोल जाना
क्लोजअप की जिंक फ्रेश टेक्नोलॉजी दे 18 घंटे लंबी ताजा सांसें क्योंकि लव ग्रोस धीरे धीरे
भी चले
ओके जब फ्रेशनेस हो ऑन लव चले ऑन एंड ऑन क्लोजअप आपस में घूट खान चकर
Tadpam Tanila, Zantukona took many no. Chanan Kai Alang, it's the open to which one cut. No himself, young Europe would raise their Burum, Nile, some Brasis, really got hung to the Unikata, Gozum Sata, Hayaro, Pilla, yes, Nikurmuch, Vadi Vafa, Janamas.
बदल मंद सठागुस बरम्या मासा बदल मंद सठागुस ऐ के दरमान से
It's so rich, so intense. It's best enjoyed bit by bit.
Good afternoon, everyone. We welcome you back for the much more enlightening sessions. Understanding the sexual health is an integral understanding the person as a whole. And this session aims to highlight the clinical and the sensitive approaches required in its assessment. We now move on to a topic that is often overlooked yet vital to holistic mental health care. That is clinical perspective on the assessment of sexual health.
It is our pleasure to introduce our esteemed chairperson, Professor Dr. Om Prakash Singh, sir, who is professor and head of Department of Psychiatry at Midnapur Medical College, West Bengal. A recipient of several prestigious awards and orations, sir has made outstanding contributions to psychiatric education, research, and professional leadership. Sir, we request you to come to the stage to chair our next session.
We have our second chairperson for the session is a distinguished clinician, teacher, and a mentor, Dr. Muhammad Aslam sir. Throughout his career, sir has been deeply committed to advancing the psychiatric services and nurturing the next generation of psychiatrists in Jammu and Kashmir. Please join me in extending a very warm welcome to sir to chair the upcoming session and introduce our speaker for the next session.
I think we are running late and we have to manage time and doctor. But the is this now, no, no, listen. In our make question, there's so many awards that
मैम लगाऊंगा नहीं आपके नहीं अभी
awards and chairs. He's co-chair of Psychiatry Human Sexuality Section WPA. He's also president-elect of SSM, which is the sexual organization of sexual health. Also, he has formed Journal of Psychosexual Health, which is doing quite remarkably well. More than 346 papers. Marfati and Dale and Murthy Award. So, sir, please, we invite you to for your lecture, sir. Thank you.
Nothing to say more. Is a distinction.
Good afternoon, everybody. At the outset, I'm extremely happy that one of the area which is neglected but which needs attention, the sexual medicine has been given a due place and time. When I saw this title, Clinical Perspectives on the Assessment of Sexual Health, there are two ways it can be done. One is actually very seriously the range of investigations, scales, and many such other things to do too. In fact, as organizers suggested to me, that would be simple and clear cut, and maybe this session should be for sensitizing people related to the field of sexual medicine. So there are a lot of things one can look into from assessment point of view, but today's presentation will focus on the aspects of psychiatry. There are many learning objectives from this, and I believe at the end of this particular session, at least some of the areas where in your psychiatric practice, you should keep it in mind and try to have this particular idea in mind. When young people have come, couple, when they actually want certain areas to be attended, they are having schizophrenia, depression, they are on antipsychotics, antidepressants. Each of these areas, how actually you can be sensitive to their problems and plan from the beginning itself. That way the difficulty can be avoided. As an introduction, one of the old statement from Charles Darwin is that we don't know many aspects related to sexual medicine. And a very recent textbook, if you open the same story, that means we are still lagging behind as far as many aspects which are concerned with sexual medicine. Sex lies at the root of life, and we can never learn reverence of life until we know how to value this particular area. Two, what actually the Master Johnson's mentioned, that ignorance is one of the most important aspects which is actually producing problems. Not only the clients and patients who come actually with difficulty, what they're actually talking about it, but we as professionals ourselves are still lagging behind in this particular area. Sex is an important aspect. It is actually something totally different. Some people may talk to. And very recently, last week, I was talking about in Adicon, the chemicals which produce the reward mechanism involved, and whether it is a behavior or a substance, ultimately the things are almost same. We'll come to that point a little later. Of course, we're all well aware, happily married. In fact, in our department, there was a fellow who was very happy. Then when we were trying to ask him and went into the details, his wife is somewhere in Cochin and this fellow very happy at this place. So happily married people, this is one of the aspects what we can see. And see, if you try to look at this, one of the advertisement which says that you sleep on this, everything would be fine. You get very good sleep. But unfortunately, many of the times we are sleeping with the enemies. That's the whole difficulty. And what Woody Allen mentioned, love is the answer for all the problems in the life. But while you are waiting for the love to happen, sex raises some pretty good questions. This is one of the important point. And among all the troubles, particularly when we are trying to talk about men in general, anything which affects their sexual functioning is one of the very dominant theme which actually creates difficulty. In fact, the tragedy in the bedroom is actually something very significant. Many people get carried away by the idea that when we are talking about sexual medicine, we are purely talking about sexual performance. It is not so. There are wide areas, aspects which are involved, like say starting from what we call sexual behavior to sensuality, intimacy, orientation, and reproductive health. So each of these areas one actually definitely need to look into. In brief, what one can say, there are many positive things which people have attributed why this particular aspect needs to be kept in mind while dealing with the people. Starting from opportunity for expression of passion and maybe affection, admiration to our growth, whole range of things actually one can look into. Earlier, sexual medicine used to be there in the section on psychiatry. Now it has been taken off. Reasons could be many. But important aspect when you are trying to talk about either mental, physical illnesses or sexual disorders, there are few things which are common. One actually what one can definitely say, low self-esteem, interpersonal problems, dissatisfaction, low quality of life, they all have been very well documented. The other important point is actually the substance abuse, anxiety, depression are extremely common, whether cause or effect, go hand in hand. And more than anything else, in fact, people don't continue the treatment what you have advised. Not because of anything, they produce sexual problems. If you just spend little time, you'll rise. In fact, the treatment emergent sexual dysfunctions is one of the major topic for which, in fact, definitely one has to keep it in mind. So the important point what we can note is actually the medications what we use, non-adherence and what we call relapse, extremely common. When we are trying to talk about assessment, in our JSS, there is a sexual medicine clinic and diabetes clinic, they are side by side. The diabetologist was telling, earlier people refused to take medicine properly, do exercise means they don't involve food control. But now once they tell or understand that sexual problems will come up, their whole attitude has changed and they're so cooperative. So this is one of the area which actually gets out. As an introduction, I can tell you, many of the young people who are here, we don't ask questions. Not because of anything, but we ourselves a little hesitant about it. This is one of the most important area. Why this is important, I'll come 1 or 2 minutes later. We should ask because whatever illness, whether you're talking about medical, psychiatric, or sexual, in fact, there are many reasons for which actually you definitely need to look into and collect information. One important point everywhere it has been recognized, actually patients don't come and tell you about their sexual problems. The point is, this has to come as a proactive decision from your side to make inquiry. What can be inquired? I'll come 1 or 2 minutes later. One, directly it could be a problem related to the sexual functioning, or second, now extremely important, it could be one of the earliest clue of the sexual, in fact, organic problems that may be coming out. Very well documented evidence related to coronary artery disease and quite a few other disorders. We are all well aware. And I still remember the sildenafil citrate initial trial when we conducted, almost about 20% of the people, first time ED evaluation documented that it was actually diabetes mellitus, which was actually contributing to the problem. So complication of both psychiatric and other related things. And there is one small study is there. If you don't ask, about 10% of the people will come and tell you. This may be one of the sexual medicine-based clinic. But you ask any extra one question, do you have any sexual concerns to discuss? The number increases by about 50%. That means we are just missing out, not because people don't have problem, but actually because we are hesitant and we don't talk about. And if ignored, you may be treated as negligent and extremely important it is. And when you are trying to talk about what we call evaluation, one important area we should keep it in mind is actually psychiatric history and maybe the sexual history. I have a psychiatrist in Mysore. He says, any patient talks more than 5 minutes, I refer them to your hour. The reason is we are so hesitant, and sexual problems means a lot of history should be collected. This is one of the very common prevalent idea. This is one of the skills developed by one of the major international center. There are only about 4 questions you definitely need to ask, which actually can provide, in fact, opening. The icebreaker, can I ask you a few questions about sexual matters? That means you are taking permission. Second, have you been sexually active with a partner in the past 6 months? And the 6 months is one of the terminologies for a whole range of dysfunctions to disorders. That minimum problem should be documented for at least for about 6 months. Of course, third question related to whether with men, women, or both. The fourth question, to bring it to what we call current level, do you or your partner have any sexual concerns to discuss? Watch list. In fact, these are all just 4 questions which can actually make so much of difference. This is what actually people have documented. When we ask our post-graduate to work up a case, initially, in fact, if it is a case of depression, they will ask about libido. If they are dissociative state, they'll ask about sexual trauma and related areas. The whole idea here is actually, there are few things well documented and well known, and only that particular inquiry people try to make. It is not going to solve any problem. In fact, there has to be sexual histories covering from the beginning up to this level, how things have progressed. And we are all well aware, any one complaint like even headache, there are about 8 to 10 different questions we actually inquire how actually the problem is happening. Coming to prevalence, this is one of the area we have to have in mind that, in fact, I go a little bit differently. Any person I meet on the earth, there are sexual problem cases. Yesterday, today, tomorrow, that's all. You got the point? The point here is extremely common. And this is one of the diagram. If you don't look at very carefully, you are likely to miss it out. There are more than 5 horses. But all said and done, unless you look at very carefully, you just feel it is an artwork or something like that. And what are the things which are there? Plenty of studies are available now. And just to quote 1 or 2, epidemiological study of sexual disorders in South Indian rural population. This is one of the study we did, and it is published actually. And so also, Dr. Shukumar and others are here. Sexual disorders among the elderly, an epidemiological study in South Indian rural population. All these studies have documented problems are extremely common. In fact, because of lack of time, I will not go into the elaboration of those things. But world over, one thing actually everybody has agreed is almost about 1/3 of the males and half of the female population has sexual problems. This is. And if you try to look at, you treat them with antipsychotics, antidepressants, the rate goes by double. That means this is one of the area we are actually very commonly missing out in actually to look into. And a time was there when almost we all used to talk about psychological, this is there in the head, and many such ways we should talk about. When we started looking into the data from maybe urology clinic, diabetes clinic, other endocrinological disorders, we realized that these problems are extremely common and not treated properly. Or in fact, when you want to treat, unless you correct some of these organic factors, you are not likely to succeed. And we are also well aware, chronic fatigue, host of minor discomforts, repeated evaluation for various things, dramatic intensity of symptoms. In fact, these are all multiple somatic complaints, aches, pains, other things are very well documented, and particularly so in case of the female population. And one of the things what one can say is, they all indicate, if you go a little well, they may have a direct or indirect relationship to the sexual issues. And unless you try to talk to those people in greater time with confidentiality and in privacy, you are likely to miss out on important area. When you try to talk about evaluation, many ways one can go. Every case definitely needs evaluation. And one thing I must always say is there are about 3 important things for sexual problem evaluation. One is history. What is the second one? It is history. What is the third one? It is history. Unless you spend some time. In fact, there are only a small number of cases where extensive, very detailed evaluation is necessary. In your clinical practice, very easily you can make out. And what we actually did one study on retrospective cases of about 200 plus from the hospital and another 200 plus from private clinic. What we could found was almost about 50% of the people who had presented to us were related to one or other myths and misconceptions what they have. And among those people, half we had one or other specific problems. 80% of them had again myths and misconceptions as one of the. And the variety, nature, and the extent of problem actually prevalent in the society and in certain communities and certain particular religion is actually something extremely common, and one should almost always keep it in mind. We are also well aware whether individual problem or couple problem. Extremely important. Sometimes only man might have come. But let me tell you, it is actually the woman who has actually sent him to go back. About 40, 50-year-old man comes and talks about sexual issues. You do remember this fellow is in love with somebody, and there is actually that lady has told there is something or he wants to prove some point. These are all very commonly encountered and observed findings. One should almost always keep this particular point in mind. And partner presented as normal. I still remember one fellow, young fellow came and they told me that I'm having both ED and I am having ED. And please treat. When we went through the details, he had married for 4 years, a distant cousin sister's daughter. She is having something like sexual aversion disorder where she doesn't even allow this particular fellow to come near. At the end of 4th year, in fact, he went and told his mother-in-law, I can't wait any longer, I want to marry. He went, they told him, come tomorrow, everything would be all right. It's a big house, they had put up the cot. When he went home, there were about 5 or 6 ladies, each one holding one arm, one leg, and pelvis, and they told him actually perform. He was not able to. Sir, I'm having sexual problems. No, you got the point. History from evaluation point of view, extremely important. Start from totally innocuous, maybe the least anxiety producing area too. In fact, this particular approach, people have called it as a funnel approach. And we are all well aware. See, for example, if you look at the clinical practice guidelines, which is published, predisposing, precipitating, maintaining factors, we definitely need to look into and see what best, in fact, each of these areas, which are actually the individual is actually having problem. You need to evaluate history starting from the early childhood up to the current level, and current problem, the extent of problem, and actually this current problem, how it has affected the individual and the partner. These are all some of the important areas we definitely need to look into. And each of the complaints, just like any other physical complaint, what you elaborate in detail, extremely important that here, starting from the duration, circumstances, description, patient sexual response cycle, partner's response cycle. In fact, all of these things have to be collated together and one has to do. And in any case, if you try to look at whether we are talking about CBT, we are talking about couple therapy in general, one important point actually people have found is a high level of myths and misconceptions and anxiety which goes along with that. And this is the one which actually produces the problem at the right time. And keeping this in mind. One more other thing in the beginning itself, what you need to establish is in evaluation, whether it is a dysfunction or relationship problem. He is not able to perform with his wife. He is able to perform with somebody else. This is a relationship problem. It is not sexual problem at all. Straight away, in fact, you'll know where actually you are progressing. And for some of you young people who are interested, the sexual dysfunctions as one of the clinical practice guidelines was elaborated in great detail. and you must definitely look into. When we are trying to talk about problem and evaluation from psychiatric perspectives, the level of analysis. Many of the people have come for some problem. He is unable to perform actually sexually, and you advise PDE5 inhibitors or something like that. That is one. They are looking into the very small area, but it has affected his family, and this is one of the many of the other related aspects. Definitely, one need to keep it in mind, and whether you look at problem as one of the very small area, or it is something really big. In fact, these are all extremely important points to be kept in mind. Let me tell you, when sildenafil citrate was introduced, all men and women believed that all sexual problems have got solved. I can quote one study which came up about 2 years later on 2000 plus couples from China, documented that hardly anything has changed. What was actually missing was what we talk about, emotional satisfaction. I'll come 1 or 2 minutes later. Now, very recently, we were there in one of these ad board meeting, and the whole discussion related to many specialists who were there, established endothelial dysfunction. And once endothelial dysfunction is documented, you treat them with some particular specific. That's the end of the story. Who is having time to talk to the patients, relatives, and spend time and all that, and how do you monetize all these type of things? These are all few of the things what many people believe, but we as psychiatrists or psychologists, we have to definitely just have to go about. When we are trying to talk about evaluation, one important thing is actually whether we are talking about dysfunctions or any related things, it is actually the sexual response cycle, and we are all well aware the male is very fast, he's almost like incandescent bulb when it comes to sex, and woman, in fact, slowly, in fact, people, when I compare to iron box, when you put the switch on and slowly it heats up. That means there is a wide difference between men and women which has been documented. There is something called as refractory period. And this is all what they actually read about, I should perform this, that, and all, many of these type of things actually generates such an amount of problem, and range of what we call sexual performance related disorders are attributable to this particular fact. If you look at our international classifications, ICD-11, of course, sexual dysfunction, sexual pain disorders, only we concentrate on that area. DSM-5, almost the same, but maybe there are 1 or 2 small areas where there is a difference. One important point, what actually they have documented is actually what we call female sexual interest and arousal disorders. Women are difficult to understand. What is desire component, what is arousal component, we don't know. Ultimately, they solve the problem by putting both the things together, and sexual interest and arousal disorder. This is actually one of the terminologies. The point what I am trying to convey, these classifications, as it stands now, they are highly handicapping as far as management and whole range of issues. The comprehensiveness which is actually necessary is actually missing when you follow these things. This is a WPS system which talks about 2 major components. One is actually what we call STD, multi-axial formulation. The other one is what we call second component, idiographic or personalized formulation. In fact, this is, it has not become popular, not because of anything, but somehow the people who are working on this area, they left out in between, and it has stood at that particular level. And for regular assessment and evaluation, including all these things may be a little difficult, and that's why international classifications also have stayed back. One important point you should watch there is clinical disorders, axis 1. In ICD-10 or maybe 11, we are all well aware they are the reason for which actually they are seeking help. But here, sexual disorders, axis 1A, and concurrent other mental and general medical disorder, axis 1B. This is one of the major evolution actually what has been seen, and this is extremely important, and I think I strongly advocate there has to be some changes that need to come about. The second, disabilities. Starting from personal care, occupation, spouse or partner with other relatives, social, general, starting from what we call none to massive, different degrees. Scales are available in this whole system. One can actually make the assessment. Contextual factors. In fact, in certain major metropolitan areas, the whole lot of things. In fact, there are 10 people living in one single room tenement. So you imagine the type of difficulties actually these people may be going through. Family, education, economic, cultural, personal, majority of the areas extremely important for our understanding and management, and we definitely need to look into. And there is a scale called what we call quality of life, starting from poor to excellent, which makes assessment audit, in fact, a visual analog scale, very easy for making assessment. Okay, trying to look at actually how it can be managed. Ultimately, a proper evaluation, how to improve libido, acquire and maintain erections, and delay ejaculation as far as the males are concerned. About women, I'll come 1 or 2 minutes later. And we are all well aware that there are a few very routine tests which definitely need to be done. Metabolic syndromes are extremely common problems that need to be actually properly assessed. And only in those cases where a very specific relevant investigations are necessary. And the two, if you are planning something little more extra, then only this other question comes. So we are very clear about what need to be done. Hormones. For all practical purposes, at one particular stage, hormones assessment not necessary what we talk about, but now the whole range of research is available. The metabolic syndromes, particularly take an example, hypertension, diabetes mellitus. There are a whole range of chemicals released in the body which actually acts as blockers. And this is what is called a secondary hypogonadism, wherein, say, for example, FSH, LH, prolactin, testosterone, maybe both total and free, they come into handle this thing, and thyroid, other related area, where we definitely need to have proper evaluation and try to take actually assessment. Plenty of skills are available. There are few things in our one country being developed, from translation to, in fact, validation. That work is happening, but still there are few things only which are actually available for our proper assessment. But if you want to do a proper greater study, a multi-centric study and all, like, there are plenty of scales are available. And this was actually dealt in great detail, almost about 30 plus different scales which are there by Grover and Anish. And this is available on, in fact,
Sir, 5
open
minutes more.
5 minutes more. Okay. So when you are trying to talk about sexual dysfunction, there are a lot of things we definitely need to keep it in mind. It is present for a certain length of time. Lifelong acquired, generate situational, mild, moderate, partner relationship, that whole area. The same story applies to gender dysphoria. Minimum 6 months, and actually we need to definitely take into consideration. And what we call paraphilic and such other disorders. I'm little running fast because I think both the chairpersons don't like me. They're cutting short the time. Jokingly I'm telling. Okay. Okay. So there are a whole range of disorders, paraphilic, why we call something as paraphilic, and many such other things. And when we are trying to talk about treatment, this is enhanced treatment formula, that permission giving, limited information, specific suggestions. With this, actually, we can cover quite a few problems. There are only a small percentage which actually need what we call intensive therapy. Establish in the beginning only whether he is psychotherapeutically, in fact, what we call adequate or not. Unless psychological, what we call sophistication is there, some of the intensive therapies and all, actually, we won't succeed. And this is one of the very common formula. Ignorance common, educate them, cultural taboos by permission giving, poor communication skills. And if a particular specific factor which is responsible, correct it, and a small percentage of individuals where it is actually done. When they are talking about men, because arousal tissues are at one particular place, any drug or injection or whatever chemical, in fact, it can make wonders. But when you are trying to talk about women, it may be a totally different area. We'll come to that. And almost all what we call clinical practice guidelines, there are about 11 what we have reviewed. The first line therapy now, in the last 1 decade, it is actually the use of PDE5 inhibitors. There are a whole range of issues related to PDE5 inhibitors, and somehow we psychiatrists are not comfortable or somehow not commonly using it. Absolutely safe, except there are some relative contraindications are there, you need to definitely keep it in mind. All PDE5 inhibitors have an excellent efficacy and safety profile. No evidence of one is better than the other. Use different PDE5 inhibitors and a la carte method. Direct comparative studies are lacking. And what we basically call give opportunity and reach. Dose titration starting from the minimal to high. Many of the times, taking the tablet and sleeping maximum hairs on his head will stand up. To trigger nitric oxide mechanism, there are few things actually what individual need to do. These are the few things what I can definitely say at this level. And we have, in fact, we have documented one of the cases published, almost 1,500 to almost 2,000 milligrams per day. Absolutely nothing major abnormality what we had found. Accident consumption of almost 800 milligrams of sildenafil citrate, nothing major problem has happened. And this is one of the important formula, not one, where actually the peripheral PDE5 inhibitors, maybe central apomorphine and central conditioner like testosterone and sildenafil citrate, all permutation combinations actually, they work and one can definitely use. And people definitely need, particularly those who have actually some problems. Comorbidities are extremely common. Unless you properly evaluate, you are likely to miss it out. Coming to psychiatric disorder as a disorder on its own right can produce problems. We are all well aware, both qualitative and quantitative problem. And at what level? So far, at one particular point, the illness producing problems. At another point, in fact, the drugs what you are using actually creating difficulties. Any drug which affects dopamine can create problems. And automatically there is inverse relation between prolactin and dopamine. In fact, these are all very well documented. Antipsychotics. There are only few drugs which have been found to be extremely useful. Now, aripiprazole alone, in fact, stands out, and Q-tipin and blonanserin and few of those other cariprazine have some better profile. So when you are trying to look at mood disorders, depression itself, antidepressants what you use, each one can produce difficulties. And this is one of the area, in fact, many people definitely need to keep it in mind. Many of the antidepressants have been used for the management of premature ejaculation. Lifelong and acquired, antidepressants are significantly useful. Maybe the natural variable and premature like, in fact, we have to go by what we call a different mechanism. And serotonin. See, serotonin acts like an inside body, a schizophrenic molecule. Those which act on 5-HT1A, they are the drugs beneficial. And all the other things actually can produce difficulty. Paroxetine. Paroxetine has been extremely commonly used. But you increase the dose slightly more, it produces erectile dysfunction also. Because it acts like a nitric oxide synthase inhibitor. So these are the few important points you should definitely remember. And this is one of the very recently appeared this picture which gives very clear idea about, in fact, among those drugs at the bottom level, the strength of evidence very strongly talks about aripiprazole, bupropion, and the drug vortioxetine. And those people who are interested, read about our editorial, what we actually published related to the antidepressants and usage. Vortioxetine, vilazodone, two things which have been actually found to be having the least amount of effect, but one is partial agonist, another was actually complete. Okay. Both are same, but all said and done, what works in case of man doesn't work in case of one emotional satisfaction. This is the point what I was mentioning. It is somehow missing. Just like, say, somebody doesn't get good sleep. Those even they are sleeping for more time. And many other such these things, the emotional satisfaction is one of the important area, which is actually. And there is a significant orgasm gap. Actually, women not actually being, one of the study we did on almost 500 plus wives of what we call Rotary and Lions Club members, almost around 32% reported masturbation sometime and only about 12% were reasonably comfortable. Any inhibitory female sexual problem, this is the treatment by training the woman in masturbation. So that means many women in our country may not even know what is actually the satisfaction rate. So there is a wide difference between man's sexual drive. They want more and have more partners. Female, whole range of sentimentality, romance, and other things actually get into the picture. That's why the treatment becomes difficult. What Marston Johnson mentioned is actually something which is related to purely physiologic. Something more. David Reed's what we basically call seduction, sensation, surrender, reflection, talk about very poetical way the woman's sexuality, what we need to do. Another about 1 minute. Man's arousal to, in fact, orgasm, it is a straight line. But in case of women, it is actually very roundabout way. This is the Basson's theory, what it talks about. At the peak of sexual arousal, also she may be worried about whether the child's bag is ready or whether the curd is set or not. You got the point? She cannot enjoy. That is the whole difficulty. That is one aspect. The second, fantasy alone. See, men can close their eyes and fantasize very easily, but women find it very difficult. Because anything actually to be fantasized, same man, husband, wearing the lungi, wearing the pant, wearing the shirt, roast. Something else, they feel guilty. Touch and touch alone. They are based on touch and other related things, actually, the importance which has been given. And with the vibrators, the thing, in fact, it is found to be actually, it is possible almost 100% of the women. Now, we don't talk about frigidity or anorgasmia. We talk about pre-orgasmic state. And We reviewed editorial on flibanserin, bremelanotide, but of course, all these drugs only in a small number of people only, actually, it helps. So the carry home message, management of male sexual problems, there are plenty of methods are available. Management of the female sexual dysfunction means plenty of things are there. And this particular picture, what I have given, giving the woman little freedom, that is what is necessary. I'll give one small case. A lady came and told that I'm so tired. She gets up very early morning, 4 or 5 o'clock, and then goes to Bangalore, comes back, and again night she has to prepare breakfast and lunch for the in-laws, and come back, and again she has to prepare food. Fully exhausted. The treatment in this case is not a problem of sex therapy. It is appointing a maid at home who can take care of and keep her a little free from issues. Important issues, there are plenty of these things are there which definitely need to keep in mind, starting from pre-morbid. No man can be made into a Superman. And what we talk about, dysfunctions cannot be treated in isolation. They are all relationship problems. Without looking into the relationship, into this treatment, we nowadays talking about relationship issues. This is one of the new book which is on the way. IPS book of sexuality, sexual online, anybody can actually access, and we have this fellowship and diploma programs also. So with this, let me thank you for topic on sex should never be so fast and hurried. You got the point. Thank you very much.
Hello, excellent presentation. But to me, history is more important regarding physical, sexual, and psychosocial. Regarding partners, practices, protections, and past reserve aside.
Thanks.
Thank you.
Thank you, sir. Sorry to rush you, but there is no other option. We are already late, and organizers are very. So, any questions or comments from audience?
What is that? SSRIs are worst as far as the females are concerned. So straight away, one point. There are drugs like flibanserin and bremelanotide, what I mentioned. See, bremelanotide is on melanocortin mechanism. Flibanserin acting, and again acts on 5-HT1A mechanism. So these things have been found. But let me tell you, flibanserin, if you try to look at range of double-blind studies that have been done, no study says if somebody doesn't improve by 8 weeks, no meaning in further continuing that particular thing. As far as the woman's female sexuality and more particularly hypoactive sexual disorder, range of other psychotherapeutic to other non-pharmacological treatments are extremely important. And one of the editorial what we published, the sildenafil citrate, off-label use of some of these things people have definitely tried has been found to be useful.
Thank you, sir. Thank you. Over to the organizers. Thank you.
Thank you.
Thank you, sir, for shedding light on such important topic.
Now, we kindly request our chairpersons to felicitate our respected speaker, Dr. T.S.S. Rao, sir. Thank you, sir. We now request Dr. P.T. Shiv Kumar, sir, to kindly felicitate our chairpersons, Dr. O.P. Singh, sir, and Dr. Muhammad Aslam, sir. Thank you, sir.
When a catastrophe strikes, whether a conflict, a flood, or an earthquake, the immediate global response tightly focuses on the physical survival. This is a reality a few places know better than our Kashmir Valley. Decades of chronic instability, coupled with devastating natural disasters, have created what experts now call an epidemic of mental distress. We now move on to our next session, the Kashmir model, access to mental health during catastrophe.
It is our great honor to have with us Professor Dr. Savita Malhotra ma'am, currently serving as senior consultant at Fortis Hospital, Mohali, a distinguished academician, clinician, and a visionary leader in Indian psychiatry, as the chairperson for this session. Ma'am retired from PGI Chandigarh after an illustrious career spanning over 42 years, serving as dean and professor and head of Department of Psychiatry at PGI Chandigarh. She's a recognized leader and resource person in mental health and child mental health at the national and international level. We extend a very warm welcome to Professor Dr. Savita ma'am, and it is indeed a privilege to have her chair this session today.
It gives me an immense pleasure to welcome Dr. Jagdish Raj Thapa sir, a senior and highly respected psychiatrist from Jammu. As the chairperson for this session, sir is widely known for his clinical excellence, deep commitment to patient care, and his long-standing contribution to the growth of psychiatry in Jammu and Kashmir. We are truly honored to have him with us today. Please join us in giving a very warm welcome to sir in chairing this session and introduce our speaker for the session.
We are now in the next session, and here the topic is very, very important and problem of disaster and mental health care during disasters, how it is to be done and what can be the different approaches and models. That is the subject of discussion, and today we have none other than Dr. Mushtaq Barghoop Saab, who will discuss and present to us the Kashmir model. May I call upon you. This audience does not need a formal introduction, but many of us who are not from Kashmir should know that Dr. Mushtaq Barghoop is the retired professor head from the Medical College and Institute of Mental Health, Srinagar, and he has been a very active, as I said in the morning, actively involved in the mental health care in the not just the city of Kashmir, but Srinagar, but also the whole of Kashmir. And he is still active, and his work is in the community, basically. And he has, from very close quarters and maybe first hand, seen and gone through and handled problems of, here it says catastrophes. So catastrophes of various kinds. These are earthquakes, or can be floods, or can be any other catastrophe. So he has published extensively on this topic and is continuing to do research on consequences of trauma in the generations. So here we are there to listen to Dr. Mushtaq Barghoop on what is the Kashmir model that he thinks works about mental health services during disaster and catastrophe.
Thank you, Chairperson, Professor Savita Malhotra ji, Chairman, Dr. Thapa Saab, and distinguished faculty, colleagues, and students. Good afternoon. वो आए घर में हमारे खुदा की कुदरत है, कभी हम उनको और कभी अपने घर को देखते हैं. Because these words reflect that madam or the institution PGI Chandigarh as such would be connected with life, and whenever we would meet, as she referred earlier, there would be definitely मैडम का तो जबरदस्त शायरी, और जब हम बात करते थे अपनी बात करने से पहले, तो इसलिए आपको मौका है एक. और really I thought I was missing something, and I was going to tell you that I would also have loved to be in the other hall, because I was of the impression that Professor Sanjeev Jain was presenting actually there, and so thankfully he is here. So when we say about this access to mental health services in catastrophes, actually the principle is that the services should be available, they should be accessible also, and they should be effective. When you talk about when there is complete disruption of the services, this is actually in general when there's a man-made disaster, it is altogether a different kind of a, some of us who were in the other hall, it doesn't actually reflect the whole process, because rest of the things are intact. People otherwise also extend support, and then the rebuilding of life starts next time. But it is altogether a different thing when it is a man-made disaster and with other disasters also. So Kashmir that way is a unique kind of a situation, and I will be mostly reflecting about that. And when we talk about, first of all, as I said, 20 years back, same place, same hall, we did talk about trauma, and that time also we had actually the distinguished faculty from other places, but today is definitely a landmark day for Jammu and Kashmir psychiatry, because this national conference being held by the psychiatrists of Jammu and Kashmir in collaboration with the Indian Psychiatric Society. But that time also we did talk about traumatic source and actually the solutions and things like that. The whole faculty was here, and these were the PGs whom we were training, and now they are the actually the professors. So then again, this is 20 years back, this is 10 years back. We did talk about the same disaster response, resilience, and recovery. And now, this is 20 years, and a new history chapter is written because of this conference. So things are moving in a very positive and encouraging direction, and I'm thankful and appreciate the efforts of everybody who has been associated with this. So we know actually these events during the past few years have impacted almost the whole humanity. Because it's not that event or those people only, we can say it. This is actually what happened in just one country, if so to say, or two countries where, but we know it impacted the whole world. This also in nearer to our region as such, you know, actually the people who get impacted actually have lot many issues, and this is just here only. The recent clash on the border or between the two countries in Jammu and Kashmir resulted in damage to civilian property as well as displacement. If you would say that there were not so many casualties, but the issues are lingering, so that has to be considered. So high rates of exposure to traumatic stressors in disasters, wars, may temporarily or permanently alter their capacity to cope, their biological threat perceptions, and their concept of themselves. Traumatic events and the way people cope with them has a crucial role in development of, we know, post-traumatic stress disorder, major depressive disorder, and generalized anxiety disorder. This is otherwise also known multiple childhood events and then traumas, stressors. But there are some faulty assumptions that Western treatment for trauma are universally applicable is highly problematic. In the other hall just now, what Dr. Bahar presented actually from the real life, even there you could see that actually there is much more for the psychiatrists, for the mental health professionals, for the trainees, and for the trainers or the faculty to learn and pass it on to. That cut-paste solutions are not our solutions as such. But equally problematic are the amusing assumptions that PTSD is a socio-political diagnosis rather than a psychological entity. Some of you who were in the other hall, Dr. Gulbahar referred in the film to this process that we have actually not recognized and realized the not only impact, the reality of trauma in our community and society. And we are so lucky and happy to have Professor Sanjeev here. I will refer to that why. And I would advise all of you, the youngsters, that please keep yourself abreast with the ground realities of our place. And for that, this is something, what happens when we talk about traumas. Why did I say Western concepts? Because, there are so many other things which are there to support your social security process, even when an individual is impacted with any adversity or things like that, not to speak of the whole community as such. But just in that aping sort of thing, we have unfortunately restricted our activities, even as mental health professionals, only to impact the event takes place, and then few weeks or few months, when so many people from other side, so many agencies from government side, NGOs and other people go, and that's why this is heroism. The people are themselves also motivated, are the people in the surroundings, and then there is all altruism, optimism, gratitude. This last 2 to 3 months, usually we see that after that starts the disillusionment. People are left to fend for their own needs. All those promises for moon and sky are just disillusionments only, and then there are issues. And I would again like to quote this one example. We think that publishing something on trauma immediately is a very something that which is an extraordinary service you have done to the profession or to the people, which could be. It is appreciable that yes, somebody or some people do document that what happens in acute stress. But the problem with us is that trauma literature, what we have, 50 days, 20 days, or third day of grenade bomb explosion, you would find things like that. Most of the things like that, when we don't consider actually psychopathology, bereavement, grief, processing, give some time for that. Give 2 to 3 months for that, and then see who are the people who need us. But what happens there? Somebody is hospitalized. After 22 people were, out of 70 people who were admitted, 22 people suffered from acute stress reaction. While as we know that 30 to 40% people are prone to get PTSD. I wish that our psychiatric society or a group or Western zone or some individuals would have taken at least initiative to see what happened to those 22 persons after 6 months, after a year, after 4 years. Was there any psychosocial intervention that was really done? So here is a big gap. And how do we fill it? That should be a big challenge. That should be one of the messages from this presentation, that would have been very easy. 22 people are not a big kind of affair. So here I would like to not debate and discuss about PTSD, whether a reality or not a reality and things like that, but I would just like to refer to documentation, how important documentation is. We know about 2 million civilians died in Vietnam and 1 million of combatants. Well, as 68 or maybe a little here or there, Americans who were bombing and in fact, they died, and you still say that those veterans are suffering from PTSD, which is not getting addressed. Oh, this is such a problem. What about the remaining population? I usually quote this. This is actually maybe 2013. Yeah, 2013. There's a conference in Vietnam only, and a coincidence that I was also a co-chair, and Dr. Saab is here. So we were there. So she was presenting, their director was presenting actually about their issues. This was schizophrenia, epilepsy, depression, anxiety, alcohol abuse. Where is PTSD? I asked her, why is PTSD? said, no, PTSD, no, we don't. It is not documented. But see this. The highest rate of PTSD reported, this was reported just after 3 years in British Journal of Psychiatry following floods in Vietnam area. This was compared with Sri Lanka, where they had also had man-made disaster as well as this was much lower than that. So is this transgenerational transmission of trauma that people are at the highest level of manifesting PTSD, but nobody is asking them. Nobody is knowing about it. So these are some of the things that we at our place will have to. But for that, I think if you really want to educate yourself, train yourself, please do have a read of this treasure. Professor Sanjeev Jain is here. Thank you very much for this. You have done a favor to the whole fraternity, to all the people who will come in our fraternity as such, provided we move a little and move the pages of this, because this tells us about the partition. He tells you about the medical actually institutions. They were the first target. बेटा इसका देख लेना क्या हो रहा है. So he has actually and Alok Sarin and Professor Alok Sarin, they have together actually documented the whole trauma where millions of people were impacted, but you don't find any reference. Leave alone textbooks, we don't discuss even about that. But we are just now also referring, he has explained it, Professor Malik Saab and others actually, who have been real stalwarts in our profession as such, when they are, for that matter, this Mantu, Saadat Hasan Mantu would be from the art and culture side, and this is actually Anurad Kala, Dr. Kala Saab, who that time was actually not born, and actually his mother was just pregnant. He details about that, and then you will find actually the horrors of India-Pakistan partition unfolding at the stroke of midnight, 47, and the lasting effects it has left, and they have explained it there. The third, this is actually normally what you say, animosity. This is actually, political kind of information that is fed to us. Here is a psychiatrist who actually is a co-author of this, and we should actually update ourselves if we want to know about the catastrophes and their impact as such, and how would that huge gap be filled if we have not talked about for so many or almost half a century about our sufferings. How do you expect somebody to come forward and you go, do you suffer from PTSD? Hey, we think that yes, you have suffered this and that. If we have not shared this at any level so far, in spite of so many things happening in culture or medical or other kind of politics, we have not talked about it. So this is something. Disorders, but reshape the emotional fabric of entire communities. Stress reactions and trauma ripples across generations. Social behavior and communal processes are deeply altered. Healing requires integrated psychiatric, psychosocial, spiritual, moral, whatever you might call it, all these ingredients. Rigid protocols must give way to responsive community-rooted solutions. Mental health interventions must reflect real need, not recycled templates from this or that classification kind of manual or source or resources. Community consultation and cultural sensitivities are essential in recovery. Now we come to Kashmir model. Kashmir model, everybody has contributed among the seniors. Professor Savita is here, she did refer to that. So this model in a way, but I will not be mostly referring to what was happening till say 2010 almost. And for the simple reason of time constraint, otherwise there are many more things that went. So I have just put this because the Kashmir model, I have tried to describe it with the three foundational pillars. One, we saw abrupt, overwhelming trauma and multiple disasters, so my reference would be to that. Then community education, services, research training amidst these harsh, real-life humanitarian crises. So it was real life there. Now I would try to take you on just some snaps of I have deliberately deleted videos because otherwise I would take a clipping of half a minute or 1 minute because that would tell us many things about that. So you'll bear with me. The crisis abruptly, we saw that armed militancy in Kashmir in 90s that triggered a psychopolitical crisis, which was unprecedented scale and widespread trauma, leading to loss of thousands of lives, severe injuries and disappearances and detentions. Then there was some more than that also what was reflected in the film, that missed persons, half widows, and then so many other processes associated with that. Countless children got orphaned, widowed, women widowed, and communities displaced. The devastation extended beyond physical destruction to cultural disruption, including the mass migration of minority community. The scale of suffering deeply was unsettling. So began the hidden epidemic. And this is a reflection of that process. And I remember Professor Sanjeev would be with us during the 90s, and we would be discussing what was possible, what could be done, knowing that there was no psychiatric services available in any other place other than one center, that is, which was otherwise most stigmatized place of Kashmir, that was known as Pagalkhana. The name was given Psychiatric Disease Hospital. That was something which was supposed to be, taking care of everything. So this is actually the data. All people from Kashmir Valley, from Ladakh, and adjoining areas of Jammu province would be, but you can see the jump in the number. So it was not only the quantity wise, it was also when you see earlier studies or earlier data, the difference, almost 40% of depression we were seeing, whereas earlier in 85, it would be only 5% or 6%. So PTSD was non-existent. So drug abuse, there are different reasons for this. Drug abuse disorder had declined, but Dr. Basu was telling me about my paper. This is the reason. See, now you see it is only 1.94 because they would not come forward. There were middle organizations would kill them, but this had not vanished. This was there, was not getting reported. This is actually the women and children, as we talk about the most vulnerable group. And this was the study that was quoted by, if there is somebody from MSF, when they came Kashmir in the same hall, here only, they were asked, why have you come? What is the reason? Then they took out this one study, and then another was from Sierra Leone, that look here, what is happening to children? And then they said, we'll be going to grassroots level. They are now moving to that level, but it has taken 20 years to really reach there. This is a psychiatric disease hospital. This got gutted in 96. And you can imagine, this was a closed kind of setup, operating just custodial care. And now, because of these pressures, there was OPD running. This is how it was. So the same organization, that is MSF, rebuilt a portion of where they started recreational and other things, activities, and some counseling in that. And then this was again Sawab, supporting always, wholeheartedly, all broken-hearted. The state government was forced to start rebuilding some portion of the hospital because they had declared in the assembly, the stigma was to such an extent, they would say the opposite, member of the opposite, you were also seen near Kathi Darwaza, the place. Yeah, this was a statement you would find. And then they had declared that we don't have any money to rebuild the hospital. So MSF started it, this Sawab PIL, they again rebuilt it on the previous. So seeing all this, an overwhelming kind of, suffering, but we hardly helping them. We were only two people there. Dr. Thapa Saab knows it, in faculty, 2 lecturers, that was all. Because Professor Beg had sad demise, it was in 96, and after that, in fact, Dr. Hamid Saab and myself were there, 2 lecturers, that is all. And you had to cater to this whole. Aslam Saab was there. And in faculty, we were 2 people, 3 or 4 psychiatrists more. That is all what we had. So one had to resign also. I resigned because no PGs were coming. But then when these 3 brilliant doctors, they joined it after an interval of a decade almost, there was no PG coming. So one felt more interested, and that is how things have moved. And rest is history. They are contributing, and we all are here because of their kind of, leadership. I had a video also which would almost give you glimpses of all these, that this is what was happening in the community. So sitting in the OPD as such would not satisfy you, what you were seeing in the community happening. So you can find this young boy in between. He was actually 6th class student. His teacher was in his presence. Dr. Sab knows about it. His teacher was tied with a tree, and he was killed in his presence, in the presence of the class. This was in a rural area as such. He started with severe PTSD, and it took us 3 to 4 years to get him out of it. Then he had some memory related issues and other things, but he unfortunately died. So he died when after some time. He was that time 11th standard student, developed malignancy, and he died. Then his another brother also died. On that 40th day, there is a specific day when they say this, there is some, he went for getting some bread. He was junior to him from Nanvai, and he got crushed there. Now only one sib was left, one son is left who's hard of hearing. The mother had severe, she was almost psychotic, roaming around, and it has taken you all these years in the community, initially treating them, then rehabilitating. A small shop has been provided to this traumatized family. The father is looking after that. The lady you are seeing on the left side, she's a grandmother who received even bullets herself. Her 3 sons got killed in one incident. The daughter-in-law also got killed. And then she had a 9-month-old child in her lap who had to be breastfed by this elderly lady because nobody would come. This is 96, when, militants and counterinsurgency, the militants from other side as such would be. It was so horrific that people would hardly go there. And it's a long story. Again, PTSD, ECT she is one of the ladies where I was compelled to give ECT, and now that has come even in guidelines and international guidelines. That was a sort of compulsion we had, how to handle such situations. So I will not give you the details, otherwise. So this has to be an overall global mission for this. The state of mass trauma marked extreme fear, large-scale loss of, and in fact, pervasive phenomenon of disappearances and detentions reflected a scale of suffering that was deeply unsettling. To address such an overwhelming mental health needs of the people, an innovative and out-of-the-box initiative at the community level was urgently required. So this is how this Sawab came up. Initially, you would go almost all alone. We would say, what would from our, treatment protocols, what type of protocol would one individual? No, it was the community resources. You would sit with them, and then, as was the concluding words of Dr. Bahar, that hope. No, it was most probably Dr. Sanjeev who said that latest MSF, he had attended a trauma-based conference recently, where somebody who had worked from MSF only in 3 or 4 countries of trauma as such said that the only thing that at least you should attempt to do is give them some hope. So this was actually under that. Otherwise, being realistic, what could an individual do? I would sometimes take my children, my 2 daughters, and somebody from clinic initially just to go and sit with some families over there. But then, mashallah, this team had come. After a few months, the PGs joined, other volunteers joined, and then this took actually the birth. So this ethos was rooted, this model was in collaboration, compassion, cultural sensitivity, and accessibility. That is when you say about access to this in catastrophes, because we said that it should impact the individuals as well as collectively the community as such, if you talk about access to, in catastrophes, access to services. But the reality was that transformation of Regions Psychiatric Diseases Hospital into a center of excellence was the only way to achieve the model of community-related goals what you had set. So this was actually, this is 2000, maybe 12, that this core group was left and the activities were started. So the points में ठीक है जनाब मैं बहुत this क्योंकि this is Dr. Arshid is to be blamed. He said is he here? He said, sir, no, you go on. I told him that I have excluded these because this is something which we don't are not able to restrict it to. But anyway, this is only one. Please, there's a caveat that before this, Dr. Shah Sahab and others, Aslam Sahab, have extraordinarily contributed. It is not that. We could only carry it on. Hamid Sahab was actually the head of the department for 15 years, 96 onwards till 2010. So what I am reflecting here is 3 years only till I left. So maybe in the hospital, because this is how things happened. I will now quickly just have a, so it started changing. So the training, rigorous training or whatever you say that was also going on. We even established a laboratory section where again, Dr. Sanjeev helped us in, because this was genetic study. We did, this was ICMR project where we did actually pharmacogenetic study. We did a neuroimaging study. We did neurostructural study of this because we were said, why did you change the name from this? What neuroscience is? So this is something that was the answer. We also took a benefit of this and established a community center, name at least community center in our general hospital. And then this was taken as a model for rest of the North states, because for 5 years, they had not been able to, spend that money. So in 3 months, we had done it. And this is actually when we talk about past and future, this was. But one thing is left for, I don't know whether among those professors anyone is here. This is still left. This was actually for the rehabilitation of the chronically ill patients. There were 35 canals of land that was earmarked. But anyway, that is now history. These are models. This is one model which actually made following the earthquake in Pakistan. They had thought of shifting them to Lahore and Karachi, all orphans. It was because there were about 70,000 people died. So all those orphans, but the three, Dr. He was president and he was also editor of Pakistan Psychiatric Association, Professor Haroon, and then Dr. Trivedi ji. We were 3 associated with this. And actually, unfortunately, both of them are no more with us. But actually, this is actually the model that, because World Psychiatric Association was involved, they changed that and they kept all those orphans there because we had learned certain things from trauma in Kashmir. We told them, don't uproot them and send them to computer sciences and history. They were saying, sir, we will not tell them anything about the trauma. So that is the role of such actually models. This is another model. Again, you don't find it in the literature. 20 years one has been actually with the family, with these families, and the whole family, entire area is on follow-up. Please give me just 5 minutes. I'll try to just. Generated data also. So grief is a real. I would now only refer to this. This is the model which we are saying that when you involve, what is the task shifting and how do you pass it on, democratize our psychiatry or mental health related. This is a model which was actually originated from this place and has been taken to Canada. They have implemented it there, but here people are still thinking, what should we do and how should we address this? And grief, I will not go about. Sorry. There are 2 studies there. Anybody interested can tell you all the details about that. She's the president of this. She tells you about the importance of such a. This is actually telepsychiatry. Dr. Savita referred to the contribution that was made by her initiative, but actually this is Dr. Tara from SCARF. We were partners in this process. This whole you can find in what this innovative was. There's a film, as I said, Rainbow in Haze from Kashmir to Canada. This is there on the. So unique features were that service delivery was in the community. The model was developed, trained lay health workers and community people were involved. So this is about the education part of it. We have trained, it has shifted, redefined the training paradigm by advocating shifting psychiatric education from hospital ward to real-life community settings, often in most difficult to reach areas, and under direct supervision. Psychiatric residents and clinical psychologists participated in field-based service delivery, working hands-on with individuals affected by trauma to develop skills in culturally sensitive assessments, and that is what in the other hall we were. So this was actually the model of training people. This is actually, that is that you are on the line of control where hardly people would otherwise also you would find the residents there. The psychiatrist, Dr. Tajimul Saab, his hair sitting there. He might recall those days and would hold actually the. So this became a laboratory and a library. This is actually how PGs would be engaged. So I'm skipping this video. And with this, we also generated trauma literature, which is this journal is known as Encyclopedia of Traumatic Stress. This has 20 studies, and this has been widely actually quoted, but we published it in local kind of index journal only. We involved community. Faith healers, almost 70% of people go. I'm just ending it, madam. This is expanding. Media has been a partner. These are two slides that I would refer that this has been an ongoing process. When you are working in trauma or this situation, you cannot say, I have retired or I have my clinic to attend. You have to do much more than that. This is actually a reflection. This we held just 2 months back. This is again the topic same. This is just September where access to mental health services in community. Just about a month back, we held it. So the message is that all stakeholders, particularly mental health professionals, both at collective as well as at individual levels, have multidimensional roles during various post-disaster phases. Small steps taken by individuals might be most unnoticed, but they can be the most enduring and endearing. Thank you. Thank you very much.
Thank you. Thank you very much, Dr. Margu. You presented the handling of a most complex and difficult situation. And sorry that we had to hurry you up, but then this was the need of time. And thank you very much. So we are already late in our program. So maybe, do we have time for one question or not? Okay. And one question or comment, anybody? Thank you.
United Disaster 26%. In prevalence of.
To reply this?
Huh?
You want me to reply this?
No. I have said bigger
Comment?
1.9% was there. 1.9% was, you have shown 1.9%. It was in 2006. Huh? Yes. Now it has increased to 19%, 19.8%.
I will reply to you, sir. Aslam Saab. Thank you very much for asking this question, but please, madam, give me some time to explain it. That is why I said that this is supposed to be an encyclopedia of traumatic, because when there was 9/11, Kessler said that in Manhattan we couldn't have enough of professionals, psychiatrists, psychologists to study the whole Manhattan area, and our resources were limited. This is USA, and this is 9/11. Mushtaq Margoob and his team has conducted 2 years study in community And after that, which is so widely said that in Kashmir, this PTSD is 15% lifetime and 7.4 was the current PTSD. Those were the days when I was at receiving end, people would be questioning me in national conferences also that is it a valid diagnosis? Is it a socio-political diagnosis? I would just like to explain it. If Dr. Zayed was here, Dr. Majid was here, maybe Dr. Arshid was also that day in a small room, in a cubicle, that is all what we had in that mental hospital. There are three, I have those photos also, I didn't get them. There were three people sitting patients, Dr. Manuji, right? Three patients. Then Majid and Zayed, I remember. So on one side, one chair, there is a BSF man who is accompanied by another BSF man because those days BS9 didn't have enough of psychiatrist patients would come to us. Then in between is a lady whose brother she had seen getting killed and she was suffering from PTSD. I have some of the psychiatrists who are here, I have presented it earlier. She is still alive, still suffering from chronic PTSD. On the third chair, I don't know, maybe there was a militant. That was the scenario one day. What Aslam Sahib said, actually, we hardly have documented the real community-based PTSD. If at all we have talked about PTSD, we have talked about initial days. You don't talk about PTSD. When I talk about PTSD, I talk about only about chronic PTSD, which is valid. And our PTSD, from what you find in the literature, that is mostly with the veterans. There is civilians, this PTSD. So yes, you are very right. It is 15 or 19. It is 15% in the community. Thank you. Thank you.
Thank you. Thank you. Thank you very, very much. Thank you. Thank you very much.
Thank you, sir, for such an amazing and enlightening session. We kindly request our chairpersons to felicitate our speaker, Dr. Mushtaq Margoob, sir. Thank you, sir. We now request Dr. T.S.S. Rao, sir, to kindly felicitate our chairpersons, Dr. Savita ma'am and Dr. Jkcips25, sir.
कर सर कर सर कर सर कर सर कर सर ओके हाँ तो
Thank you, sir. We now move to our next workshop titled From Screening to Support the Dementia Care Continuum. This workshop focuses on a subject that is becoming increasingly important in both clinical and community psychiatry, that is dementia and the evolving approaches to its care. Through this session, we will explore the continuum of dementia care, understanding how timely screening, accurate clinical assessment, neuroimaging insights, and compassionate management can work together to improve patient outcomes and enhance patients' quality of life.
We are fortunate to have a distinguished panel of experts who bring years of experience, research, and clinical wisdom to this topic. This session will be moderated by our very own Dr. Junaid Nabi sir, Associate Professor in the Department of Psychiatry at IMHANS Kashmir, a teacher, a mentor, and clinical par excellence. Sir is known for his academic depth, compassionate patient care, and visionary leadership in strengthening the mental health care services across the region. Kindly extend a warm welcome to the sir.
Good evening, everyone. This is a very important session. I know it is very late and you will be very tiring, but I hope with great speakers we have in this workshop, it will be very engaging and very interesting. And at the end, PGs or SRs who will be actively participating, they will be given a surprise gift. So I hope everyone will be very much into this session. That will make it more fruitful. And so when we talk about dementia, dementia is not only a diagnosis, it is in fact a syndrome which starts well before diagnosis and which remains with the person lifelong. The most important thing will be early intervention, diagnosis, and evaluation so that the outcome is better and faster. To chair this important session, I will like to Narsim, then MD and DM from NIMHANS, Bengaluru, currently working as assistant professor at addiction medicine, NIMHANS, and has been awarded Best Research Award 2023 and Best Research Grant Award 2023, AIMS, and another distinguished chair will be Dr. Shashank Singh Sena, who has done DM in geriatric psychiatry from King George Medical University, Lucknow, and he is currently working as an assistant professor in the same institute. So over to chairs, and so that we can start the program. Thank you.
Thank you, Dr. Junaid. I think this is going to be an important sessions for postgraduates, particularly because it is going to cover a wide range of clinical topics and starting from assessment, radiology, and prescription practices. So, without wasting much of the time, we would like to invite Professor Preeti Shukumar to talk on approach to patients with cognitive decline.
One more point. Questions will be, it will be an interactive session. No questions at that. You can ask the speaker in between, and so that it becomes more of a workshop rather than a speech and one-way traffic.
So, good evening, everyone. I would like to thank the organizers, Jkcips, and also particularly Tajamul and Junaid for having me here and having this session. I also thank the chairpersons for the introduction. So we are already 2 hours late, and this was conceptualized as a 1.5 hour session. We need to see as to how fast we can actually conclude it in a crisp manner. So what I will try to do is focus on the assessments. Dementia is something which is evolving very fast, and the practice of dementia diagnosis and treatment in the next decade is definitely going to much change compared to other psychiatric disorders. I think this is one disorder where we have a threat of being taken away from psychiatry. Already there was a threat in the previous diagnosis. And if we don't upgrade ourselves and then practice, there is more chance that it becomes much more challenging for psychiatrists to manage. There is a when this condition is something which does not have much of a promise of any treatment. Primarily, it was with us for behavioral and psychological management and supportive care. But now I think it's fast changing. There are lots of people who have a potential to be helped if you identify rightly, and there is some treatable causes. The scope of the treatable causes is also changing. And psychiatrists have a lot of responsibility because many times misdiagnosis happens, and then we are also responsible for iatrogenic effects. Many of the patients with psychotropic I think a lot of material is available, clinical practice guideline from the IPS, as well as there are articles from Alzheimer's Association, which gives a comprehensive approach about diagnosis and evaluation. So I would like to emphasize on the clinical aspects of it. So primarily we need to see whether is there a really importance in kind of diagnosis and subtyping. So how it is important? Anyway, it is not something, majority of the conditions doesn't have a curative treatment, but nevertheless, there is a scope, that's what we would like to argue. And most of it, I think previously Dr. T.S. Rao highlighted in sexual health assessment, how important is history. He repeated 3 times, and I think this can be repeated multiple times with dementia. The only difference is here it is not one person, you have to get it from multiple family members. It's not just a couple, you have to get from multiple family members. So history is something very, very important, and to have a conceptual understanding is important. Dementia is something is emerging as a public health priority, primarily because of aging population and numbers. And these numbers is something not a fiction. We are seeing it in our clinical practice, how people are seeking help. And all of us will see more and more patients of dementia because of longevity. I don't want to go into details of the numbers. 1 in 3 seconds is anywhere in the globe, people are being diagnosed. What are we calling as dementia? To refresh, any impairment in the significant decline in cognitive domain in 1 or more domains. Complex, it is not just memory, that's what is important. ICD emphasizes requirement of having 2 domains impairment, but the most important thing is there should be interference with the functional impairment. Everyday activities is getting affected, and you have to exclude delirium and other major psychiatric disorders or iatrogenic effects as a cause for this problem. Now, ICD has 2 domains, but DSM emphasizes even 1 domain significantly affected is dementia. Now, this is the global data. Across the globe, more than 5 or 6% above 60 years having. Incidence, again, age-associated increase in incidence is happening. Now, this is important. In India, we have now data that the latest study from the Longitudinal Aging Study of India estimates the prevalence of dementia in India, 7.4% of people above 60 years. What is important and interesting to note is that Jammu and Kashmir has significantly higher prevalence compared to the average. It is 11%. We don't know why. I was thinking literacy, whether it's the issue, but even literacy is above average compared to the national average. So literacy alone will not also explain whether this is a misdiagnosis, but some of this needs further exploration as to what is the reason for this being higher. So, so this is something people from Jammu and Kashmir needs to study. Now, how does patients with dementia present to psychiatrist? Most of them, there are people, when there is a cognitive decline, people go to psychiatrist, neurologist, geriatrician or physicians. They can go to anybody. Psychiatrists are the one who get to see a lot of people. Primarily when there is a behavioral change, many of the patients with dementia actually come for consultation, not just because of memory problem, because of the behavioral change. Because the awareness that memory problem is actually due to dementia or it can be a decline. It is not just as a part of normal aging, is something very, very limited. So most of the reasons why people come, is it because of psychosis or mood symptoms, personality change, agitation, aggression. That's why psychiatrists make an important role. Now, various behavioral problems which are important indicators of dementia. For example, REM sleep behavioral disorder. The FTD has a specific pattern of behavioral symptoms. Many times it is seen as depression and then it is being treated. So we need to pick up those kind of conditions. The other important context now is almost all the patients, we need to think whether there is a medico-legal issue. We have to ask a question, why they are coming now? So they have dementia, they have cognitive problems. Why are they coming now? What is the context? Many times people are brought not because of consultation for treatment, because in the context of some property disputes, legal issues. We have forensic psychiatry chief sitting here, Dr. Suresh. But we need to keep this in mind when we make an impression of dementia, knowingly or unknowingly, your documentation might influence certain decision making. It can be used as a record. So we have to have a responsibility when we document a person with dementia. So this can be a very, very important factor. And sometimes it is people are brought wandering and then they are brought for consultation. So that can be the issue, or it can be referrals. Now, there is also a context where you might get referrals from somebody who's admitted, where a person could have delirium. Delirium is common in elderly. Delirium is also common in elderly who have undetected dementia, particularly when they undergo some procedures, when they are getting any treatment in the hospital, they can develop more easily, they can develop confusional states. That's when the context of referral may come. So if you go beyond the acute issues, then you can actually detect the underlying dementia. And depression as a comorbidity. And also many times there may be an ongoing decline, but when you start using some psychotropics, particularly THP, particularly anticholinergic drugs, either for any urology issues or other indications you've used, then it can precipitate. So rarely you may get people with rapidly progressive cognitive decline with behavioral issues. So if you see, there is a large kind of variations in which the context in which people may come. It is not always the memory complaint. Behavior can be an issue, or a legal context can be an issue, or a rapidly progressive decline. Sometimes it can mimic with dementia, severe dementia also it can mimic, severe depression also it can mimic. Now, the question as a clinician, what we have to ask, is this anybody when you are seeing 60 and above, you need to think a new onset of a problem. If there is a new onset of a problem, you need to think, are we handling a person with dementia or a neurocognitive disorder? Is this a condition, a dementia mimic? Or what is the specific underlying etiology? In psychiatry, always we don't need to think of etiology in most of the patients. In schizophrenia or bipolar disorder, we are not thinking of etiology. But in elderly geriatric psychiatry group, we have to always think of secondary etiologies. What is the cause? It could be some other secondary cause. It could be a treatable cause. It could be a iatrogenic cause. So that is very important. We have to think of what is the etiology. And then we have to be optimistic and looking at how we can treat the person, even if it is a condition which is not curable, whether is it partially treatable. A person may have dementia, but they may have multiple other risk factors which can be addressed and then which can contribute to improvement of quality of life. So we need to be optimistic in addressing those factors, right from sensory impairment like hearing and vision to mobility issues. You prevent certain damages. So you are not addressing just cognitive problem. You need to address the person as a whole. So how can I help the person? So that is important. So I think I would emphasize on this picture, which is from the recent guidelines, which has come in Alzheimer's and Dementia Journal. This is one of the comprehensive document. There are 7 cores what they talk about. The first goal actually is to see why am I evaluating this person. So we need to have an understanding as to what is the scope of evaluation. Many times what happens is you may get into problems, you do a battery of tests, subsequently say that you have dementia, this is not treatable. The family members may think, why are you doing so many tests? Why are you doing so many investigations? So is it necessary? Is it not obvious? And sometimes people also question that. So that is something we need to say as to establish goals as to why am I evaluating, what is the scope of it. That's very important. Then the second core is about history from the patient as well as care partner. I think many times in dementia, the patient may not be very cooperative. They may not talk very sensible things when you talk, when you interact with them. But never, even then, it is important for you to spend few minutes with the patient and ask, because that will actually tell you what are you dealing with it. So talking to the patient, if you find there are people who have come and presented from the informant, the history as dementia, but when you talk to the patient, a patient has actually been doing many things. Sometimes it will be confabulations. So if you find a gross mismatch, then again you need to have a more detailed things. And you need to talk to the patient alone and the caregivers alone. That is also important. Many times we see that when the patient listens to a lot of complaints from the relatives, they will get emotionally disturbed. Some of the family members may assume that they don't understand anything. So you need to respect the person and then have dignity and then evaluate. There are the domains what we have to evaluate. there are four important things. One is cognition, all the domains of cognitive function. So focus on cognition. Second is behavior. There are different behaviors people can have problem. Then the functional activities. When it comes to activities, very often the focus is on the basic activities, but one has to, particularly when people come in the early stages, you need to focus on the complex activities. That is something very important in our context, because most of the elderly are supported by the family members. The children don't allow them to do many activities. So if you ask them, they may not have been doing it for many years. So you have to have a clinical judgment whether they will be able to do it, whether if there is an opportunity, whether they will be able to do it. For example, cooking or any other complex activities, handling finances, all these things they may not be doing for the last few years, even before the actual decline has started. So you have to evaluate whether there is a actual decline is possible based on a clinical judgment. Then sensory motor, again, is very important, hearing, vision, because all your assessments depend on that, as well as Parkinson's symptoms, motor symptoms. This is something, gait, instability, falls, postural instability, all those things are very important. So these four domains, we as psychiatrists, we should not simply focus on behavioral symptoms. We should also focus on cognitive function and activities of daily living and sensory motors. These four domains are important. Then the history is very important in terms of other factors. One of the important thing is family history. Family history will also give you information about genetic causes, but although also the same time, in our situation, most of the previous generation would not have a diagnosis. So you need to see as to how long they survived. So if they had survived lesser, if they had died at 60 years or less than that, then you can't rule out genetic factors. So that's also something. If somebody has an onset in early 50s or 60s, even if the family history is not there, you have to consider possibility of genetics. Now the genetic testing landscape has changed significantly. You can get it actually evaluation at reasonable cost. So that is something which is to be kept in mind. Then other histories in terms of medical risk factors, cardiovascular diseases, social history, high risk sexual behavior, all those things are important. Then in terms of examination, all the system examination focused on etiology, medical, neurologic, psychiatric is important. The last step as to what are we going to come, the core 6 is important. At the end of the evaluation, what are we going to have? We need to diagnose whether this person is having normal cognition, whether this person, what is called as a cognitive functional status. The person is normal cognitive function, or does he have subjective cognitive impairment? Does he have mild cognitive impairment, or different stages of dementia? So that is the first step we have to kind of diagnose. Then second, what is the kind of cognitive behavioral syndrome based on the profile of symptoms? Is it amnestic? Is it a lot of executive function impairment, or language is involved? Or is it a mixed kind of presentation? So that phenotype actually gives us a clue for the etiology also. To some extent, there is a correlation. This is not absolute, because you can have a frontal variant of Alzheimer's. You can have, people have the mismatch of pathology, and the phenotype is very much known because of the biomarkers. You will, in the future, we will diagnose dementias, etiologies using biomarkers. Again, that is something very important in psychiatry. There are not many disorders we have biomarkers to diagnose. This is one condition where biomarkers are already in place. For example, in demands, we have recently started CSF biomarkers as a clinical diagnosis. Till recently, we had used CSF biomarkers as investigational tool. We would collect sample and then do the standardization was not there. Now it is available as a standard clinical investigation. So that is very important for us to keep in mind. The third aspect is the etiology. The etiological landscape is also changing because of the emerging availability of autoimmune test and paraneoplastic test, as well as the biomarkers we need to keep in mind. So these three aspects, what is the cognitive function status? What is the cognitive behavioral syndrome? What is the etiology? This is the end of the clinical assessment in terms of diagnosis. Okay. So why are we diagnosing? One of the things is that implications of wrong diagnosis is something very, very important. So we need to think that dementia diagnosis is not something like a cross-sectional. Even if you consider something like, if you are not sure, keep a time and then look at prospectively over 3 to 6 months, then reassess, then communicate. Because casual communication of a diagnosis of dementia can do more harm and it can lead to a lot of problems. Legal as well as the personal distress, how it happens, it can be problematic. So there are, if the patient is not progressing, if the patient is not deteriorating, again, you have to reassess the diagnosis. So that is something very important for you to be careful in making this diagnosis. This is not a simple diagnosis to make. And the diagnosis needs to be communicated in a proper manner. That is why you need to have a proper diagnosis, because always people look at as to what is the prognosis, how long the person will survive, what is the kind of challenges what they have to ensure, what is the staging. So this is something like not just making a diagnosis, it's important to communicate it in a proper manner. Disclosure of diagnosis is important, which very often in our context happens in a very casual manner. And then once they have a better understanding, half of the management is done by the family. It's not about medications, it is about the family, how they manage. And a need to develop a personalized care plan and avoiding iatrogenic use, particularly in our context. If you are treating psychosis, then you will use a particular kind of drugs, particular kind of dose. But if you are treating as a BPSD, your target will be different. So you will be more cautious in using the medications. So iatrogenic effects can be minimized. So these are the responsibilities what we have, why we have to make a diagnosis. So I think I have covered most of this. I think I will rush through because I think this is the conceptual approach. This is the most important thing what till now I have spoken. So I think already have diagnosed. So when it comes to psychiatry, there are few important differential diagnoses. I will talk about that. And we need to know about the staging. We need to know how more and more in future, the diagnosis should happen in the MCA stage, mild cognitive impairment stage. We now see people in moderate dementia, but over a next decade or so, we will see people in the MCA stage more often. Also, preclinical diagnosis will be possible. So a simple diagnostic approach, what one should have when the person comes, if there is a kind of progressive decline is there, then we are considered dementia. If there is no decline, we have to think whether it's a mental retardation or intellectual disability. If there is a consciousness deterioration, if there is a consciousness alteration, then delirium has to be thought. Whether multiple cognitive functions are involved, we have to see. Otherwise, it's a isolated aphasia or amnestic syndrome. Whether serious interference in daily activities is there or not. This is how dementia approach is there. Now, depression and dementia is the biggest conundrum what we often face. We have I don't want to read all these things, but we need to know that there are certain indications. There is a concept of pseudo-dementia. It's no longer pseudo-dementia because depression and dementia, there is a lot of overlap. So one needs to actually don't think in terms of pseudo-dementia. It is a treatable cause.
5 minutes.
Yes. So this is something we need to, when we have a differentiation, we need to treat depression as a therapeutic stance and then use optimal because it's one of the most important treatable cause for us. So one should not always see this as an exclusion. It is not depression versus dementia. One has to see if there is a component of depression that gives you a scope for treatment. So that's why, and if you look at what is the evidence for treatment of depression in dementia, medications don't have that much of evidence, but brain stimulation is something one has to use. Don't worry about cognitive decline or cognitive impairment with respect to brain stimulation. If you actually treat properly, there will be improvement of cognitive function if depression is the underlying cause. And if it is dementia, it is not going to worsen. Brain stimulation is not going to worsen the cognitive function. Same way, FTD and bipolar disorder, again, it's a clinical diagnosis. It is not just based on imaging. Now, more and more PET is used. PET, when you use PET, it is much more sensitive, but there can be possibility of a wrong diagnosis. We should not go by only imaging. We should go by the clinical diagnosis and we should look at the progression, what is happening. Because both depression as well as bipolar, they will have cognitive impairment to some extent. And it is not just the presence of cognitive impairment. You need to see how much extent it is affected. That is very important. And using the imaging as a corroboration, we can make a diagnosis. Psychosis, again, psychosis is another important thing. People with FTD can present as psychosis in the initial phase. So again, it's important differential one has to make. So we have already talked about subtyping. Even though the current treatment is primarily for Alzheimer's, whatever the symptomatic drugs, what is available is primarily for Alzheimer's. One need to understand if you use donepezil or cholinesterase inhibitors in FTD, there can be worsening of the behavior. So one should know subtyping to some extent. When it is clear you can use these drugs, at least don't do harm. That is a concept what we need to have. Certain things like SSRIs can be helpful in FTD. So I think Tajamul is going to speak about treatment. So the subtyping, even to an extent, it can help in choosing the treatment and also help in prognosis. So various etiological diagnosis, I won't go into the details now. We have a long list of investigations, which is the article which I talked about in Alzheimer's dementia. It gives 4 tier of investigations. So tier 1 is done for everybody, which includes B12, folic acid, CT or MRI. And there are other investigations which are done for when there is a clinical indications. So I think these are the reversible causes of dementia. I think already we have talked about how history is very important. If there is an early onset, which is less than 65, and also if there is a rapid progression, that requires a more exhaustive evaluation. And so if there may be a person with dementia, but if there is a worsening is rapid, still we need to look for treatable causes. So I won't go into time. I think subtyping, different diagnostic criteria are there and different. The primary symptom is what are the associated symptoms, how is the onset and how is the progression. That helps in subtyping along with the imaging features. So the challenges, again, multiple history doesn't end in the first consultation. You need to keep reviewing the history. Very often the caregivers also have cognitive impairment. The spouse may be accompanying, they may not be the good informant. So you need to look for multiple informants. That is important. And paid caregivers are the one maybe there. Somebody may come from old age homes. Again, it's important. So there are structured tools which has to be used. Many of them are available now in Indian languages also. This can be used. So physical examination, investigations, LP, the indication of LP now with the CSF markers, biomarkers available for Alzheimer's disease, you have to select and use for proper confirmation of diagnosis. It can be used. Soon, disease modifying drugs will be available even in Indian context. That's going to add the complexity of when we have to kind of use it. The blood biomarker also may be available in the soon. So I think autoimmune causes are quite a few, but some of them, they actually recover very well with the treatment. So it's important to identify those things, even though a lot of people may not get improvement despite treatment. So a lot of seronegative causes also are being treated nowadays. So this is evolution of biomarkers, which can be helpful in the evaluation process. We need to understand and then evaluate use the fluid markers. Blood biomarker also are likely to come in the near future. So there's a lot of mixed etiology can be there. It's not about one diagnosis being there, others will not be there. But ultimately, when we manage, we need to look at a comprehensive management with a focus on personalized care. For the behavioral management, this one important principle of describe, investigate, and create and evaluate DICE approach is very useful. That is something for the BPSD. So I'll conclude. So when we look at dementia diagnosis, we need to have a comprehensive approach. Early age of onset and rapid cognitive decline, again, is something we need a more intensive evaluation. And it's not just enough to diagnose. We need to actually have a comprehensive approach in communicating, and post-diagnostic support is also important. I don't think we will be able to address all these aspects in today's kind of program, but still there's a lot more to be done. Thank you very much.
Thank you, sir. I think it's a wonderful taking us through, starting from the history, taking to the radiological and other investigations. I'm sure our young residents will have a lot of questions. So if there are some questions, if there are awards for chairpersons, then we will take more questions and take awards. But so over to you, to the residents for asking questions. And yeah, so there is a
anybody would like to ask?
Hello, sir.
Yeah.
Sir, I'm Dr. Zahman. And sir, I have a question. Sir, considering the global impact of dementia generally, and sir, what do you think the disability adjusted life years generally have an impact on the definition of dementia right now. And considering basically the caregiver burden and the neuropsychiatric symptoms, and also, sir, increasing, impact on the young generation and undiagnosed cases and early diagnosed, undiagnosed cases.
So if you see the impact of dementia as a disabling condition, it is one of the most disabling condition. Disability adjusted life years is something very high for dementia. So it is ranked as one of the most disabling conditions which does not have effective cure compared to cancer. For example, cancer also we have curative treatments are now possible. So this is one of the condition where disability is very high, but we don't have cure, and it leads to increased mortality. So people have increased risk for mortality also. They generally spend around 5 to 7 years average post diagnosis. Okay, so the impact is not just on the person, because most of the times some caregiver has to cut down work and then provide supervision and support. So the indirect cost is the most costly things. So if you look at the cost burden, it's estimated as more than 1 trillion. So that's the global cost. Large majority of them is indirect cost. So how you are actually cutting down work. So that's very important.
Thank you, sir.
That's why the solution is, again, a lot of investment is being done, because it's a very disabling condition.
Thank you. PGs should focus when they are dealing with any patient with a cognitive decline. It is important that they should focus on the history based on the cognitive domains. They should have some screening questions for memory, language, executive function, and means all the 6 domains, and then see what is the order of involvement of the cognitive domains. Is it prime, as told, that is it mainly amnestic, or other domains are also involved? So the order of cognitive domains will also involvement of cognitive domains will give the idea that which lobes may be involved initially, which lobes are involved later.
So when a very important point is that you should focus on the first 6 months to 1 year. You have to catch when is the onset, and then focus on these things in the first 6 months, because the later, most of the times, people come to us after 1 or 2 years of illness. When it is more diffuse involvement, all the domains will be involved. So you need to focus on the first 6 months before the first consultation. Even that is delayed. So you need to use the landmarks time points, any particular time point when you can establish the onset, and then look at what is the domains which is involved, what is the sequence. Most of the times people will say everything as memory. So you need to differentiate that. Give examples and ask.
Good evening, everybody. My name is Dr. Alia. So I would like to ask regarding affordability of the CSF biomarkers. Are they affordable? And also the attitude of caregivers or patients, if any, towards lumbar puncture, consent for lumbar puncture, do they readily accept it?
Yes.
Thank you.
It's a good question. So the current clinical test, what is available in demands is 5,000 rupees for each of the biomarker. So we have 3 biomarkers: CSF A beta 42, CSF tau, phosphorylated tau. It is 5,000. You can ask for a single test, or you can ask. So mostly the A beta 42 and phosphorylated tau is the most sensitive thing. So you need not ask for 3. You can even ask for 2. That should be good enough. And patient, because this is a serious diagnosis. So when particularly when will we be using? There is an article for appropriate use of CSF test for diagnosis of dementia. Okay, so if the patient is early onset, if there is a rapid progression, if there is then there is a need for testing autoimmune antibodies, not only in the serum, it's also in the CSF. That time very much important. If there is a rapid progression, if there is a young person, 99% they will not refuse. If you are doing somebody with an 85-year-old who has 3 or 4 years of typical Alzheimer's dementia, there is no need for doing CSF test in them at that point of time. But even in them, if there is a rapid progression, rapid decline, if there is a treatable scope is there, age should not be only the criteria. So that is one aspect. With respect to Alzheimer's biomarker, whether people will agree for it, this will become more useful when there is a disease modifying treatment. Lecanemab and donanemab are soon going to be launched even in India. They are not going to be used for everybody, but still we will have to kind of have a specific diagnosis, then discuss because the starting point for considering those treatment is a specific diagnosis. More accessible than the PET amyloid. Amyloid PET is going to be much more challenging, but amyloid PET also either of these things, if it is available, that should be enough. So it is not that people will refuse if there is a necessity to diagnose specifically. So even genetic tests, people, when there is an explanation, the most important concern in dementia diagnosis, people are concerned about what is the risk for me. So having a specific diagnosis can be an important factor in future, because these decision making depends on how much risk you have, what is the kind of diagnosis. So it's important to have a specific diagnosis and evaluation in all these aspects. Obviously, it should be explained. It is not a major invasive procedure that the risk benefit. If you see neurology, they commonly use these testing methods.
Thank you, sir. Thanks for all answering those questions.
So lastly, I would like to ask, since at NIMHANS you have started doing it, so lumbar puncture will be done by the psychiatry residents or you refer them to the neurologist?
That is up to us to get it done. If psychiatrists want to get trained and then do lumbar puncture, there's no contraindication. So we, in our settings, we have multiple things. There are many times we take the help of anesthetists also. When we do because ECT, we have anesthetists coming. So because definitely psychiatry residents have not been doing lumbar puncture most of the times. So we have been taking help of neurology or anesthetists. Sometimes our own people also do it. Depends on the comfort and depends on, we have to do it. That's important.
Thank you, sir.
Thank you. Thank you.
Now we'll move on to the next presenter, Dr. Jameen. Later. So, Madam will be talking about neuroradiology, how to interpret CT or MRI in dementia. Over to you, Madam.
Good evening, everyone. So I'll be speaking on neuroimaging in dementia. And briefly, we will start with the basics of cross-sectional imaging. We will have a brief overview of imaging anatomy, the dementia imaging algorithm, and a brief overview of neurodegenerative dementias. So since I was told that this workshop is mainly aimed at psychiatry residents, so to make it more interactive, we will have a question-answer based kind of interaction. So there will be a quiz question. I don't see many psychiatry residents around, but if anyone is willing to participate, otherwise I can slip the question-based slides. So you will have 10 to 15 seconds to answer the question. You can scan the QR code, and then we can build up on that knowledge base with a brief explanation. So coming to a few basics regarding image acquisition in cross-sectional imaging, which includes mainly computed tomography and magnetic resonance imaging. So you can just scan this QR code, whoever is interested in participating in the quiz. So do we have any interested participants, or I just skip over? Okay, fine. The cross-sectional imaging method of choice in emergent settings is computed tomography. So if you have a patient and you need to rule out certain urgent neurological emergencies like an acute ischemic stroke or an intracranial hemorrhage, then computed tomography is your go-to investigation. The other advantage is that with the advent of multiplanar reformations in CT, you can also assess atrophy and use your visual rating scales on computed tomography as well. So if you look at this, you can see here, this is the CT gantry and this is the patient table. So what happens in modern CT scanners, the gantry has a rotating X-ray tube and an array of detectors which make a full 360-degree rotation around the patient. And there is a horizontal movement of the patient table also. So there is a kind of helical acquisition. So the CT is image acquisition in CT is based on attenuation of X-ray photons, and you describe it in terms of density or Hounsfield units. So Hounsfield units is basically a standardized unit in which water is arbitrarily assigned a value of 0. So if you look at CT images, the CSF containing ventricles, they appear relatively black. The gray matter is hyperdense compared to the white matter, which appears hypodense. The basal ganglia will be hyperdense, the thalamus will be hyperdense because they are all gray matter structures. And then pathologies like intracranial hemorrhage will be quite hyperdense on CT. So then we have various windowing you can do on CT based on the pathology that you are looking for. For example, if you have a subacute STH, then you may have to use a subdural window, since the routine brain window might mask a subacute STH. So far as magnetic resonance imaging is concerned, it is based on resonance of protons or hydrogen atoms, which is one of the most abundant protons within the human body. Then you have a radio frequency coil, which is a receive as well as a transmit coil. There are gradient coils, which allow spatial localization. And then there is a superconducting magnet, which magnetizes the protons in the longitudinal direction. And then you give an electromagnetic pulse using various radio frequency coils and then receive the signal within the same coil. So just to show you how the basic MRI sequences look like. So the first one, this is a flare image. So on a flare image, so on MRI, you describe the images in terms of signal intensity. So here you can see that the gray matter appears relatively hyperintense compared to the white matter, which is relatively hypointense because it has a higher fat content and a lower water content. Then the CSF containing ventricles, they appear relatively black. Then on T1 weighted images, the reverse occurs. The gray matter is relatively hypointense and the white matter is hyperintense because of myelin containing tracts. The T2 weighted image looks similar to a flare image, except that the CSF will appear bright. So this is a diffusion weighted sequence, and a diffusion weighted sequence generally has 3 kinds of images. So the first image, in which you don't apply any diffusion gradient, which is known as a B value 0 image, looks similar to a T2 weighted image. Then as you increase the B value, you increase the sensitivity of the diffusion gradient. And then you have an ADC map to confirm that what you are seeing on the B value image is actually a restricted diffusion. So this sequence is useful for ruling out ischemic strokes and then certain causes of dementias like Creutzfeldt-Jakob disease, in which this is a very critical sequence. So in this case, you can see there is a bright area within the cerebellum, right cerebellar hemisphere, which appears dark on the ADC map. So this is a case of true diffusion restriction and a case of acute ischemic stroke involving the posterior circulation. So then we have susceptibility weighted imaging, which is important to detect mineralization and microbleeds in the setting of vascular dementias, and then mineralization in the setting of Parkinson's disease or other neuronal brain iron accumulation disorders. So this is an SWI image which shows multiple hypointense foci. So these are multiple microbleeds in the case of cerebral amyloid angiopathy. So just coming briefly to the anatomy. So this is an axial T2 weighted image at the level of the basal ganglia. So here you can see the lateral ventricles. These are the frontal horns, the third ventricle, and the occipital horns of the lateral ventricles. So this structure over here is the thalamus, and between the two thalami, you can identify the third ventricle. So this is the globus pallidus, the putamen, and the head of the caudate nucleus. So coming to the anatomy of the mesial temporal lobe, which is one of the important structures involved in typical Alzheimer's disease and mesial temporal sclerosis. So this structure over here represents the hippocampus. Then you have the entorhinal cortex adjacent to it. This is the parahippocampal gyrus, which is separated from the fusiform gyrus by the collateral sulcus. You have the choroid fissure over here, and then you have the temporal horn of the lateral ventricle, not very prominent in this case. So this is a sagittal section, again showing the anatomy of the hippocampus. So this is the head, body, and tail of the hippocampus. This is the part of the lentiform nucleus over here, and this is the amygdaloid nucleus. This is the hippocampus on the axial section of this is an axial T1 weighted image showing the hippocampus. So then this is another important structure, one of the earliest areas to be involved in early onset Alzheimer's disease, what we call as the precuneus, which you can typically identify on a sagittal T1 weighted image. So this is basically the cingulate sulcus, which lies just above the corpus callosum. The cingulate sulcus continues posteriorly as the marginal sulcus. So this is the parieto-occipital sulcus, which separates the occipital lobe from the parietal lobe. So the area between the marginal sulcus and the parieto-occipital sulcus is known as the precuneus, and this is one of the earliest areas to be involved in early onset AD. So these are some structures related to the frontal lobes. So this is the central sulcus, which separates the frontal lobe from the parietal lobe. Then in the frontal lobe, this area will be the dorsolateral prefrontal cortex. This is the medial part of the frontal lobe. Then this is the parietal lobe. Here on the coronal image, you can identify the insular cortex, the dorsolateral prefrontal cortex, the cingulate cortex, and the orbitofrontal cortex. So here you can see the ventromedial part of the frontal lobe, which is involved in processing internal emotional cues. And here you can see the cingulate sulcus, and along it you can see the anterior cingulate cortex and the posterior cingulate cortex. So what is the role of structural imaging in dementia? So firstly, you need to rule out other causes of cognitive impairment, such as reversible causes of dementia. Then we try to identify patterns of atrophy using visual rating scales on structural imaging. Then you need to rule out other diseases like vascular dementia or cerebral amyloid angiopathy. And then there are certain quantitative methods like voxel-based morphometry to assess the degree of atrophy. So the imaging protocol, as I have shown you, it consists of T2 weighted and FLAIR images, SWI, DWI, and then high spatial resolution volumetric imaging. Generally, we use 3D T1 MP-RAGE images to elucidate patterns of atrophy. And then you can also add arterial spin labeling nowadays, which gives you some idea of the degree of hypometabolism or hypoperfusion in a particular area of the brain when you don't have structural changes initially. So first you look for potentially treatable causes of dementia. Like in this case, you can see a large left hemispheric subdural hematoma, which is causing a lot of mass effect on the left hemisphere. So herein you can see an SWI image and you can identify a lobar hematoma. So here you can see an intracranial space occupying lesion on the T2 weighted image. So this is a case where you can see subtle T2 hyperintense signal within the hippocampal cortex, which is hyperintense on T1 weighted images, and you can see some blooming on SWI. So this was a case of hemorrhagic necrosis of the hippocampal cortex secondary to cocaine abuse. So this is another cause that we frequently encounter here. You can see these are two axial FLAIR images and a coronal T2 weighted images, and you can see hyperintensity within the medial thalami, within the dorsal midbrain, and also within the mammillary body. So this was a case of Wernicke's encephalopathy. So just to tell you about normal pressure hydrocephalus, which actually presents with disproportionately enlarged subarachnoid space hydrocephalus. And what do we mean by that is that there are dilated lateral ventricles. There are dilated sylvian fissures. However, you can see convexity tightness. That is, you can see effacement of the sulci along the convexities. You can see an acute callosal angle. And you can also see some tightness within the medial parietal sulci. So these are the features of normal pressure hydrocephalus. So then we try to identify the patterns of atrophy using various visual rating scales. So we have the global cerebral atrophy scale. So atrophy, you should generally try to visualize atrophy on T1 or FLAIR images because T2 weighted images generally tend to overestimate the degree of atrophy. So this is the global cerebral atrophy scale. So this is a normal scan over here. Then you can see some widening of the sulci. In the third image, there is some volume loss of the gyre. And then you can have knife-like gyre, which are always abnormal. Then for the mesial temporal lobes, we have the Shelton's mesial atrophy scale, in which you need to evaluate 3 parameters. You need to look at the width of the choroid fissure, the temporal horn of the lateral ventricle, and the height of the hippocampus. So in grade 1, you will have some widening of the choroid fissure. In grade 2, you have prominence of the temporal horn of the lateral ventricle. And then in grades 3 and 4, you have moderate and severe reduction in the hippocampal height. So there are various age-related cutoffs which are used to diagnose Alzheimer's disease, typical AD. Then we have a Coidum scale for posterior parietal atrophy. As I told you, this area is known as the precuneus. So in grade 1, there is mild prominence of the sulci. In grade 2, there is volume loss of gyre. And in grade 3, you have knife-like gyre with severe volume loss. Similarly, you have Kipps and Davies scale for assessing frontal and temporal atrophy in cases of frontotemporal lobar degeneration. So this is a 20-point scale which assigns 5 grades at 3 or 4 slices. Then for the assessment of white matter and other abnormalities, you need to look at FLAIR images. And we have a Fazekas grading for microangiopathic changes. So when you have discrete hyperintensities, these are grade 1. When there is early confluence, that is grade 2. And in grade 3, you have widely confluent white matter changes. Then as I said, SWI for microbleeds, like in this case, you can see a lobar hematoma. We can see some ischemic changes and multiple microbleeds, as well as some cortical superficial siderosis, which is seen in cerebral amyloid angiopathy. So as I said, overview of neurodegenerative dementias. In typical AD, you will see atrophy of the medial temporal lobe. In early onset AD, it is posterior parietal atrophy, which is initially predominant. In FTLD, you have frontal and temporal atrophy with atrophy of the anterior cingulate. However, in advanced stages, there is a global atrophy with involvement of the medial temporal lobe as well. Then vascular dementia will be characterized by typical white matter changes and also by microbleeds. Dementia with Lewy bodies doesn't generally have a typical pattern of atrophy, but you can identify occipital hypometabolism on PET images, and on that scan, you can identify reduced striatal uptake. So in dementia with Lewy bodies, you may use SWI sequences wherein you can find loss of this nigrosome hyperintensity at the level of the midbrain within the substantia nigra. So this is a case of Alzheimer's disease, and you can see almost a grade 3 mesial temporal atrophy on the Shelton scale with widening of the choroid fissure, the temporal horn of the lateral ventricle, as well as reduction in the height of the hippocampus. And this is a case of frontotemporal lobar degeneration, wherein you can identify marked temporal atrophy, which is especially asymmetric more on the right side with knife-like gyre. And there is also predominant involvement of the anterior cingulate compared to the posterior cingulate. We can see marked atrophy of the anterior cingulate over here. So this, as I said, diffusion-weighted sequences, this patient had presented with rapid cognitive decline and myoclonic jerks. And the MRI typically showed diffusion hyperintensity, diffusion restriction within the caudate and putamen, and also within the cerebral cortex, which we call as cortical ribboning. And this was a case of Creutzfeldt-Jakob disease. So thank you.
Any questions? If please give the mic.
Usually when psychiatrists ask the patients to do neuroimaging like MRIs, for example, most commonly done here, should they specify that they need dementia protocol in that? Because many a times the reports we get here are quite general. They don't mention GCA scores or MTA scores and other. So how to make it more specific? Should the prescribing clinician specifically mention that they want dementia protocol?
So yes, you should mention that you need a dementia protocol because many people skip over some of the sequences. Like we routinely acquire a 3D T1 MP rate sequence. But at several centers or in private settings, they skip up the sequence for want of time. So if you mention a detailed clinical history of the patient and mention that you require a dementia protocol, then yes. And then we can also add up other sequences, like if an ASL is available, that also can be added.
Thank you.
Any question from senior residents, PGs? A gentle reminder, there will be a surprise at the end.
May I request the third speaker, Dr. Tajmal? Tajmal, are you eligible for the award? Over to you, Tajmal.
We thought that only the residents should get it so that they will actively participate, but I see only a few of them. So anyways, congrats to them for staying so long here. This is probably the last session of the day. So I'd like to thank PT sir for coming here all the way from Bangalore for the conference, as well as Dr. Shumaila, who just gave the presentation. She's probably only few of the neuroradiologists here in Kashmir, and we often refer difficult cases to her. So, this part of the session was supposed to be given by our teacher, Professor Matthew Verghese, but because of some medical emergency at home, he could not attend, and I was asked to give this session instead. So I had to make the presentation just yesterday within one day. So I thought that I'll keep only case vignettes. I'll not be giving any talk. I'll keep only case vignettes. I don't know how much time I have. If we are able to complete all the vignettes, we'll do it. So at the end of each vignette, we'll be asking questions, and then we may have a brief discussion as well. So this is a 70-year-old woman whose chief complaint was that my memory has been getting worse. She has a history of gradual onset of forgetfulness, poor concentration, and occasional confusion over 6 months. No focal neurological symptoms or mood changes. She is on quite a few medications, oxybutynin for her overactive bladder, which was started 6 months ago, and recently the dose was increased 2 months ago. She is also on diphenhydramine for allergic rhinitis and lisinopril for hypertension. On MMSE, her score comes out to be 24, in which there is impaired recall and attention. Lab investigations and brain MRI are unremarkable. So the question is, which of the following is the most likely cause of this patient's cognitive decline? Is it early Alzheimer's disease? Is it depression? Is it cerebrovascular disease? Is it anticholinergic medication effect or vitamin B12 deficiency? We'll give the mic first to the residents.
Sir, I think the answer will be D, anticholinergic. Sir, my name is Dr. Jameen, third year PG resident in the Department of Psychiatry, GMC Srinagar. I think the answer is D, anticholinergic medication induced dementia.
So you can just keep the slide on. So the answer is correct, anticholinergic medication effect. See, a lot of patients with dementia, since they are elderly, they will come with a lot of comorbid medical conditions, and they'll be on a lot of medications. So one of the first steps is actually not prescribing, but de-prescribing, is to see all those medications which the patient is on, which can lead to cognitive decline. And if possible, either stop those medications, or in consultation with the physician, you can either decrease the dose or give alternate medications. So these are some of the common medications causing cognitive impairment. Of course, there are a lot of them, but these are some of the common ones, like the anticholinergic medications, benzodiazepine, TCA antidepressants, opioids, antihistaminics, and non-benzodiazepine hypnotics like zolpidem. So the first step will be to identify whether the patient is on any of these medications and try and either stop or give an alternate medication. So we move on to second case. A 60-year-old retired accountant says that over the past 12 months, he has noticed increasing difficulty recalling recent conversations and misplaced objects. Though he remains independent in daily activities, his wife corroborates these memory lapses but reports no major changes in judgment, personality, or ability to manage finances. There is no history of stroke, head trauma, or depression. He has a past medical history of hypertension, type 2 diabetes, and there is no past psychiatric history. He is on lisinopril and metformin. On cognitive testing, MMSE score of 27, MoCA score of 25 with memory domain impaired. He has preserved language, visuospatial, and executive functioning. Neuroimaging shows, MRI shows mild age-related cortical atrophy without significant vascular burden, and lab investigations are normal. So the question is, which of the following is the most evidence-based first-line management in this case? Is it either to start donepezil? Is it to begin SSRI for prevention of cognitive decline? Is it cognitive training, physical activity, and vascular risk reduction? Or D, initiate memantine? So again, we have the same resident. The others can also try. We'll try to give the mic to everyone.
I think the answer will be C, as the patient is having just short-term memory impairment that is not impairing him in day-to-day activities. It means that is not impairing in social occupational life. So first we will go for the cognitive training plus physical activity and vascular risk reduction like educate control of hypertension.
Very good. The answer is correct. Answer is cognitive training, physical activity, and vascular risk reduction. Why? Because this is a case of MCI, mild cognitive impairment. And in mild cognitive impairment, so the first line management will be either cognitive training, physical activity, or vascular risk reduction. No medication as of now is approved to be given in MCA except the latest disease modifying agents, which have not yet come in India. So this slide has already been discussed by PT sir, so we will just skip it. So case 3. 76-year-old retired engineer presents with 2-year history of progressive forgetfulness, difficulty with recent memory and problem solving, and mild frustration about cognitive decline. Still independent in basic activities of living, but requires assistance for complex tasks like paying bills, buying medications. On mental status, there is mild memory and visuospatial impairment with a MoCA score of 21. He has normal lab investigations, but MRI shows mild hippocampal and parietal atrophy. So the diagnosis I will give myself is early Alzheimer's dementia, mild stage. So the question is, which of the following psychosocial interventions has the most consistent evidence for improving cognition and quality of life in mild Alzheimer's dementia? Is it reminiscence therapy? Is it cognitive stimulation therapy? Is it psychoanalysis, or is it sensory deprivation therapy? You can raise the hands. You can guess also. No issues. If you give the wrong answer, you will not be charged negative mark.
So I would like to go with reminiscence therapy because we use it in patients of Alzheimer's dementia, and it's an evidence-based non-pharmacological intervention.
Any other guesses?
Cognitive stimulation therapy.
So the correct answer is cognitive stimulation therapy. See, this case I have put in here because many a times when we talk about treatment of dementia, the first thing comes in mind is the medications. But other than medications, we have actually a lot of other modalities which are evidence-based and which we can try. So there are a lot of other non-pharmacological treatments, and among them, cognitive stimulation therapy has the strongest evidence base. So we have cognitive stimulation therapy, cognitive rehabilitation, reminiscence therapy, physical exercise, occupational therapies, and cognitive trainings. So other than medications, we can also try all of these non-pharmacological treatments. Case number 4. A retired teacher, widowed, and lives alone. Her chief complaint is that I can't think clearly anymore and nothing seems enjoyable. She presents with an 8-month history of low mood, anhedonia, poor concentration, and subjective memory difficulties. Her daughter reports forgetfulness and withdrawal from social activities. She has early morning awakening, appetite and energy are reduced. No psychosis, suicidal ideation, or recent medical changes. She has a prior depressive episode at age 45, full remission on sertraline. Hypertension and hyperlipidemia, which are stable. Her mother has a history of depression. On MSc, she has psychomotor slowing, constricted affect, MMSE score of 25, geriatric depression scale score of 14. She has poor recent recall, fair remote memory, and partial insight. So the question is, the most appropriate first-line pharmacological treatment for her is A, donepezil, B, paroxetine, C, sertraline, or D, amitriptyline. There are 2 hands, so
Sertraline.
Any other person wants to answer? We'll go from here.
Sir, I think the diagnosis is pseudodementia, so we will first try to treat it. So I will go for sertraline.
Okay. So the answer is correct, is sertraline. So this case represents actually the complex diagnostic presentation of depression and dementia, which PT sir was also just now saying. So it presents with a very complex presentation. It's not that simple. There are 3 antidepressants here. So why only sertraline you would like to prescribe? Why not paroxetine? Why not amitriptyline?
Sir, as the patient in the elderly age group, and we have the SAD heart trial, which prefers sertraline, which is cardiac safe. And we will have least anticholinergic effect considering paroxetine as well here.
Yes, that is right. Plus, she has had previous good response to sertraline. Paroxetine and amitriptyline have anticholinergic effects, so sertraline would be the ideal choice. So, so this slide represents the complex the presentation in which depression and dementia can present. So it can present as depression can present as a risk factor for dementia. It can present as cognitive impairment as a feature. Dementia can present as a cognitive feature of depression. Depression can present as a prodromal symptom of dementia, or a reaction to cognitive decline in early onset, in early stages of dementia, or both depression and dementia can share a common risk factors. So in all these cases, it's very important to treat depression.
Dr. Tajmal, 5 minutes.
How much time? So this will be the last case.
Great.
Okay. So we move to next case, 67-year-old farmer with a chief complaint that I forget things more often and get lost when going to familiar places. The duration of history is 18 months. It is gradual in onset, progressive memory loss, difficulty with finances, misplacing objects, repeating questions. He has no hallucinations, depression, or major mood changes. Early difficulty with instrumental activities like managing money, navigation. However, his basic ADLs are intact. MMSE score of 23, MoCA score of 21. MRI brain shows mild hippocampal and temporal atrophy. On neuropsych assessment, prominent episodic memory and executive functions deficits are there. Lab investigations are normal, no reversible causes found. The question is, which of the following is the first-line pharmacological treatment in this case? Is it memantine? Is it donepezil, risperidone, or memantine plus donepezil? Are you a resident? So you can answer.
Based on the severity on MMSE, it's mild dementia. So we started.
Your diagnosis?
Sir, Alzheimer's disease. Steve.
Because your answer will depend upon that.
But it's mild dementia because the patient is having early difficulty with instrumental activities only. Basic activities of daily living are intact. It's mild dementia, so our treatment of choice will be donepezil.
So the answer is correct. Answer is B, donepezil. So based upon the severity or stage of dementia, the treatment guidelines say that in mild dementia, the first line treatment is plain donepezil. You can slowly increase the dose. Then starting from moderate and severe dementia, you can start memantine. And combination of memantine and donepezil has been shown to be more efficacious than either of the two. So currently, the most evidence base for dementia is for anticholinergic stress inhibitors as well as memantine. So donepezil being the most commonly used. So usually in early dementia, you can start for 5 milligrams and after 4 weeks, increase the dose to 10 milligrams. There are some SR preparations also which you can use. Most commonly GI side effects and syncope you have to take care of. Memantine is an NMDA receptor antagonist indicated for moderate to severe dementia. Weekly, you can increase the dose from 5 to 10, 15, and maximum to 20 milligrams. So not any major side effect except some dizziness and headache. So I had a few more cases, but I think the time is very less. So I think we'll stop the sessions here. And thank you for being here till late evening. And thanks to the residents for actively participating. Thank you so much.
Thank you, Dr. Tajammul. We had a wonderful session. All the three speakers gave the wonderful presentation. It was a learning experience even for me. And I'd like to summarize with few points. Like for the PGs, they should focus on the history taking, focus on the cognitive domains. After the history taking, if you are seeing the patient on the first, for any patient for the cognitive decline on the first visit, make the diagnosis of under evaluation for cognitive decline rather than making a diagnosis of dementia. We make a serial cognitive assessments and then only go for a diagnosis of dementia. It is very necessary to rule out delirium, depression, reversible causes of cognitive decline. And for neuroimaging, the residents should focus on the low atrophy of the lobes involved, infarcts, or any white matter changes. Last, when the patient is coming to the doctor, even if the diagnosis of dementia is there, rather than directly giving the dementia diagnosis, patient should be, caregiver should be psychoeducated about the prognosis, because many times we see that the caregiver burden in dementia patients is very high and their expectations are also very high. So we should deal with that. And if there are any anticholinergic medications or benzodiazepine, we should try to lower them.
Thank you.
Thank you so much. In the beginning, the way I said that dementia is not a diagnosis itself, it's a journey. So the presentation has been like that. It started with how we approach, then how we diagnose it, at the end, how we manage it. So thank you so much, all the speakers and dear chairs. So, and that one surprise, it will be a one memento to be given to the best question and someone who had been actively part of this workshop. And so I would like to call upon all the three speakers, PT sir, Dr. Shamaila, and Dr. Tajammul. And I would like to call upon dear chairs, Dr. Narsima and Dr. Shashank, to felicitate our speakers. To PT sir. To Dr. Tajammul. And the best question is someone who has participated fully, Dr. Jamil. Kindly come on the dais and get that surprise. I will request our own Dr. T.S.S. Rao sir to felicitate our chairs and myself. So this concludes day one from Hall A. We will be gathering shortly for dinner.